नहीं हो सकता लेट बजेगा ऑडियो में सुनने को जुगाड़ नहीं है वो जुगाड़ बनाना ओके अपना होगा काम फैक्ट्री हेलो चेक हेलो check 1 2 1 2 check 1 2 hello check hello check 1 2 3 4 5 6 7 8 9 10 check hello check कितना टाइम होगा होता है लैपटॉप में
और क्या है तेरा उससे मेरा तेरा से मैंने जो बोला वही वही होगा ना यार ये पूरी विंडो है ना तो विंडो पे जो कुछ होगा बाहर चले जाएगा पहले कुछ नहीं लगता आप ऑप्टिमाइज स्क्रीन नहीं करेंगे ऐसे चेक काम करें वो खत्म हो गया है हैंग कर गया लैपटॉप ये बैंड शो हर चीज तरह लेट हैंग ही कर रहा है हैंग ना कर रहा भाई चेक ना बढ़िया चेक करो काम पे चले हैं चाय ये सब अरे चाय बॉडी लोड दवा लेगा ना कितने दिन में आराम से कोई दिक्कत नहीं है कितना चेक करनी चाहिए बताओ ठीक है बस तो छेड़ने की जरूरत नहीं है कुछ नहीं करना आपको क्या करना है अभी देखो तेरी गाड़ी की चाबी कहाँ है बोला मैंने पूछा आपने मैंने पूछा क्या आपने कहा हाँ ठीक है इसको सिखा भाई इसको सिखा बट गाड़ी बना मैं चेक करना चाहता हूँ ठीक है बोला है नहीं वाला रिकॉर्डिंग चेक करना पड़ेगा रिकॉर्डिंग को जोर चेक किया 8325092 भैया भैया ओके डन और यही कितने हाँ तो मैंने बोला कि रिकॉर्डिंग पे फोन कर दिया दीपक जी बोला कि ये कुछ करो अभी वो नया बनाया मैंने।
नया बनाया मेरा नाम जो ना थोड़ा सा याद रहे कि बैकअप क्यों बना रहा है
ये वो लैंड फेल हो गया तो वाईफाई तो रहेगा ना बदला।
तो वाईफाई वाला तो इसमें वो रहेगा ना वो रिकॉर्डिंग
हैं
तो सिर्फ हाँ जी
जो रिकॉर्डिंग होगा इधर होगा उधर कुछ नहीं होगा।
कहाँ वहाँ रिकॉर्डिंग होगा
हाँ
तो फिर ये रिकॉर्डिंग क्यों कर रहे हैं बैकअप के लिए
हाँ
जब फेल हो जाएगा फिर क्या करेगा रिकॉर्डिंग का
फंड बनाना है तो इसका समझ कि जब इसमें रिकॉर्ड कर रहे हैं वो क्लाउड पे जाता है। ठीक है
हाँ उसका क्लाउड भी
ठीक है
जाता है हाँ
इन केस ये बंद हो गया तो ये चालू रहेगा। ठीक है साहब इनके लैन गई वाईफाई वाला चालू रहेगा क्योंकि मैंने इसको बना दिया कोविड तो जैसे ही ये बंद होगा तो ऑटोमेटिकली होस्ट आ जाएगा इसको होस्ट की जगह। ये जो कुछ मैं इस पर करूँगा वो यहाँ पे आएगा
होता रहेगा
हाँ
करेगा
ठीक है इसको मैंने लगाया है कि मैं इस पर अटेंडी अंदर ना करके इस पर अटेंडी अंदर करूँगा। ठीक है
अच्छा सुनो ट्रेंडिंग के लिए ये होता है क्या ये तो होस्ट है ये तो होस्ट है ही वैसे
हाँ मैं इस पे से ना करके भाई इस पे से करूँगा ना अगर कुछ होता है वैसे तो मैं इसको छेड़ूंगा नहीं।
तो मुझे चलता रहे खाली
हाँ
बैकअप के लिए हमने लगा
हाँ
बाकी हम तो खेलेंगे उसमें
हाँ
अटेंडिंग में डालना उठा के डालना है जाके भरना है और जो हमारा
मैं कह रहा था सुन मैं कुछ कह रहा था रमेश ओ रमेश रमेश ओ रमेश मैं कुछ कह रहा था मैं बोल रहा था खुजली हो रही है नीचे हो जाएगा नहीं मैं खा चुका
तेरे को इसलिए नहीं बुलाया तेरे को जाने के लिए बोला है
वन टू वन टू वन टू वन टू वन टू
आवाज नहीं आ रही है
चेक वन टू वन टू अगर इनपुट की चल रहा है एचडीएमआई एचडीएमआई करना है उसको
अरे भाई ये छिड़ गया था मेरे से तो मैंने इसको दोबारा
कुछ
मेरा ये उसको नीचे दबा रहा था मैं इसको खोलना पड़ेगा
अरे रहने दे पड़ा रहने तेरे को चूल करो क्या चूल मछली है
भाई चल नहीं इसमें
फिर मछली तो बता फूल करें वो भी उठने उठने देंगे तुझे।
भाई ऐसी बात क्यों कर रहा है
ये बोतल हटा दे पहले यहाँ से बस
भाई हट गई बहुत तो लड़ गई
तू आया तू सिखा दे जा जा उसके पास बैठ जा उसके पास
भाई ऐसा नहीं किया। भाई फोन में
CVT.org है ना आपको वेबसाइट cvtindia.org बिल्कुल लाभ देखो
फोन में ये अब ब्लैक मैजिक यूज हो रहा है क्या?
बिल्कुल आगे जाके
हेडफोन भी कनेक्ट कर दिया हमने, जुगाड़ से हेडफोन कनेक्ट कर दिया। किसमें? ब्लैक मैजिक में। तार काट दी? तार कौन सी काटी? एक्सएलआर। वो एक्सएलआर तो काटी है, ये दोनों काटा हमने हेडफोन, एक्सएलआर तो काट देंगे। उसका मतलब ये जुगाड़ तो कनेक्टर है, लेकिन एक्सएलआर बिल्डिंग नहीं का कनेक्टर है तो जुगाड़ का तो टिन्नी का नहीं होगा, तेरे का होगा फोन का जुगाड़। एक्सएलआर फोन का मिलता है वो, एक्सएलआर टिन्नी का जुगाड़ है। आरसी पहले आरसी जो दो है, हाँ हाँ तो टिन्नी आरसी है, हाँ टीम जॉइंट है नहीं लगा।
हाँ लगा ये तो रिपोर्ट की बात है। सब करना चाहते हैं मैं अभी बस करना चाहता हूँ। एक लैपटॉप लेकर बैठूंगा अच्छा यार भाई ये अपडेट क्यों मांग रहा है और रिपेयर क्यों मांग रहा है? ये मैं
का विजिट करा है तो वीडियो चला दो उसका और उसको फोन कर दो, बोला तो यूट्यूब पे वो चेक कर लो ये वीडियो चल रहा है। आप लाइव आगे बाद में करें शुरू होगा और लिंक दे दीजिए वीडियो चला दो करना उसको आपको बोलो तो बता रहे हैं कि यूट्यूब पे चेक कर लो। आप अपना लाइव आगे जब करें तो शुरू होगा तो लिंक दे दिया आप
अब अभी
Hello, sir.
Hello.
So today is your panel. I
No,
think.
not today, tomorrow. Tomorrow is at 5 o'clock.
Okay, first.
First session, yes.
Yeah, your panel on first. Okay, 13th. Okay, sir.
Everything is okay.
Yeah, fine.
I just want to check how to, because today's meeting, I just want to join the meeting as an observer, but how to enter? We have the link to this meeting.
Same link. What you log in today?
Same link, is it?
Yeah, same link.
Same link, then where now I've just come to the dry run. And what should I do to get into the live meeting now?
Sorry.
No, what same meeting now to now I've come to the dry run
Okay.
and how to enter the meeting hall.
When you click on the link,
Yes.
you automatically come to join as a attendee. I will promote you as a panelist.
Okay.
Same like today, I will promote you.
Okay. Now you will send me a link now.
Uh, no, same link for tomorrow. Same link. What you
Oh,
have login? Yeah,
now so I can join the meeting with the same link now.
yeah.
Okay. Then can I cancel and get the
Yeah. Can you please log out and log in again? I will promote you.
thank you.
Welcome. Sir. Hello. 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 Sir, can you hear me? Hello. 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 Hello.
एक भी ले सकते हो, दो भी ले सकते हो। ये 5 दिन बाद बंद कर। फीस देना। सर मेरे को ना ब्लड आ रहा है स्टूल में, ये फरवरी से मेरे को दिक्कत है, तो ये मेरी 2 महीने से करीब दवाई चल रही है। अभी कुछ टाइम पहले मैंने डॉक्टर से मिला तो उन्होंने मुझे बोला कि दवाई तो आपको लेनी पड़ेगी। आपने लेटरिन के रास्ते मशीन डाल के जांच कब कराई थी? नहीं करवाई था। फिर तो कैसे आपको दवाई दी जा सकती? वो उन्होंने बोला करवाने को, मतलब अभी 2 महीने दवाई देने के बाद बोला उन्होंने कि आपको कोलोनोस्कोपी करवा ली। क्या शुभ नाम है आपका? विवेक चंद। विवेक चंद। अब मुझे डिस्क्रिप्शन दीजिए कि कैसे होता है, आपको ब्लड कैसे आता है? लेटरिन में मिला हुआ आता है, लेटरिन से अलग आता है, टप टप।
Hello?
Yes, sir.
I just wanted to make sure, is working
Yes, sir.
because
Yeah, working.
I'll be there later today in the panel.
Yes, sir. Your panel 8:25 p.m. I think.
Okay, everything good?
Yes, sir. Fine.
Okay. I'll join later then.
Okay, sir. Thank you, sir.
All right.
Hello.
Yes, sir.
Yeah, I'm Dr. Palanisamy here. Come to join the meeting.
Join. The meeting started 6 p.m.
Oh, it's 6 o'clock today.
Yeah.
Right. Okay. Thank you.
Welcome, sir.
The same link, no?
Yeah, same link. Hello.
Senin muayesele mi yapıyor?
try the penumbra system here or any other large bore atherectomy system. So I want to.
You can also work with the penumbra system. Aspiration catheter is a very good option. Often it is the only option when you think of the more distal cerebral artery emboli, yes, where you cannot reach it so easily with a stent retriever. There's aspiration very helpful and a very fast procedure. But also here you have to be careful because when you have, yes, fixed the thrombus on the tip of your aspiration catheter, you can lose it when you pull it down, or you can lose a part of it. So it's not always one passage and everything is clear.
Okay.
So the risk with
another question would be naturally also, yes, what is with thrombolysis? Do you use additionally thrombolysis, yes or no? I use it when it is far up in the cerebral artery, not in the carotid, because that's a very big clot and it will need hours and hours to dissolve that. So it's not very helpful.
Yeah. So we have a comment coming from Dr. S.R. Vallabaneni, our vascular expert from Liverpool. Welcome to you, Dr. Vallabaneni, and maybe we'll have your comment.
Thank you very much indeed. That was an excellent presentation. I really enjoyed it. It may be of some interest for the delegates to know that NHS England considers acute thrombectomy a high priority area to concentrate on to reduce patient morbidity and associated costs from stroke. We're having great difficulties in England to get the patients who are presenting to various different acute centers with TIA or stroke as quickly as possible to the regional thrombectomy centers. For us, service delivery and organization is a problem for us. We are aiming to get about 75 to 80% of eligible patients to actually get the intervention. Having made that comment, I would quite like to know Professor Mathias's approach to any intracranial disease that you might notice. You know, the extracranial carotid disease, you can stent it, and in the rare occasions you can actually even leave it and not necessarily a good solution when you're there, but you can even leave it and wait for a delayed carotid endarterectomy. But every now and then you do see disease closer to the base of the skull and beyond the normal surgical and extracranial stenting territory. What is your approach to that?
Well, that depends. When it is thrombus, and we just talked about acute stroke. When it's thrombus, yes, then you have to get it out. But when it is atherosclerosis, it's not always restricted to the bifurcation, but it can also occur far up, yes. Then we have there also the possibility to stent it and to remove these lesions, yes. These lesions can be close to the skull base, and we have very good stents, therefore, that are not the typical carotid stent. You can use also other stents, yes. And yes, I would cover it also here then.
So you wouldn't hesitate to balloon them and then stent them. Can I also ask, do you see any guide wire induced intracranial dissections, and what is your approach to that? That is one of the things that we really dread, but I must say we all have had them once or twice.
Well, first, you should avoid dissection, yes. And the cerebral arteries are different from other arteries of our body because they have a very thin-walled adventitia. So you can easily perforate it. That's the reason why I advance sometimes the wire with a sharp G curve at the tip. So it will not go into some tiny side branch and then you push and suddenly you have perforated the artery. When you have this G curve, then you can advance it without being anxious, yes. Then never use force. You have to work gently with these devices not to damage cerebral arteries. So spontaneous dissection of cerebral arteries, it's more or less rare. The two typical diseases we have there is one is the aneurysms, also due to the fact that we have thin-walled arteries. And the other is then the AVMs, where we have, yes, to occlude the feeding arteries, so embolization treatment. With the aneurysms, we also have two options. The older one is coiling, but then you need a good neck. When you have not a good neck, it's much better than to place a microcatheter in the aneurysm, and with a second access, you bring in a stent, which will cover the neck of the aneurysm, and then later on you can coil it. So the second microcatheter is then between stent and vessel wall with the tip in the aneurysm, and you start then coiling. Then you will not lose a coil or embolize a coil in cerebral arteries. So these are the two disease entities we see more or less frequently. All the other things are rarities. Yeah.
So we have a question from Dr. Robbie George. Robbie, would you unmute yourself and pose your question to Dr. Claus?
Thank you, Dr. Atul. Dr. Claus, that was a fantastic talk. It was very illuminating. Can I ask, anatomically, when you look at the imaging, what would make you worried that this is not going to be a straightforward case, or this is not going to be a case that is going to do well with an attempt at a thrombectomy?
Yes, when you have a carotid occlusion, we have mentioned these two entities, the embolic disease with carotid T, and the other is carotid bifurcational disease. But as already mentioned, there might be also dissection. And when you have a dissected carotid artery and it is occluded, then you can run into the risks that you will enter with your devices the wrong way, not the true lumen. And that you have to find out, otherwise you make it worse than it was beforehand. So that is one of the things. When you have no way to find the way, you can also be a little bit more, inventive. You go from the contralateral side up. You place your microcatheter and wire from the right to the left side, and then you come from up to down. You catch the tip of the wire with the snare, and then you have the true way, the true lumen. Yeah? So also there are some tricks which you can use, but that is rare, very rare, that you need it.
So
it can be done.
we will have only two more comments quickly in this presentation. So one, I have a raised hand by Dr. Rahul Jindal, and then after that I will request Dr. Priya Jagia to make a comment on imaging. Right, Rahul, your question.
It's a very nice talk, and it's a very interesting case in the clinical scenario. A short question: how will you change your management in terms of a time of presentation after the acute stroke and the amount of brain damage what you see on an MR? Because how will it post-operative prevent the post-operative reperfusion injury? How will you manage that? And if it's a massive stroke, how will you manage the anticoagulants post-operatively so that patient will not have a reperfusion bleed?
Yes, first, what I have not mentioned, but that is very important, is the blood pressure. Yeah. So as long as you are working in the starting period, the blood pressure should be elevated. It should be a little bit higher than normal. Let's say systolic pressure somewhere 160 to 180, yes? Because there's always a little bit of collateral flow. And so the brain cells have a better chance to survive. But as soon as you have opened the vessels and you are in the state of reperfusion, Then you have to get the blood pressure down. The patient is in the bed, so it's no problem that he will get vertigo and will drop to the floor. He is lying in bed. So a systolic pressure of 100 to 120 is sufficient. Yes, I would like 100. Yes, because then the risk of a reperfusion hemorrhage is lower. That risk is even given when you treat not only acute stroke, but also when you have to deal with a patient with a very tight carotid artery stenosis. You also can have then, when there was not a good collateral flow from the other side, contralateral flow, then you also have that risk. It's rare, but it happens that you get cerebral edema and even bleeding with a simple carotid angioplasty and stenting. So that is, the blood pressure must be controlled. That's very important, I think. Yes. And the other thing, therefore, I give not too much heparin. There is in all the fluids we give, there is some heparin, but I'm not giving him 10,000 units of heparin from the start on, because also that increases the risk of bleeding. And then you have, yes, to see why has this patient this occlusion. Most, when it's the cerebral arteries, in most cases, these patients have a heart problem. They have atrial fibrillation. That is the most frequent cause. So in the long run, he needs anticoagulation, the patient. Whereas when it's only the carotid, then you can work with anticoagulation medication with aspirin or clopidogrel or similar things. Yes, that is no problem. But when it is coming from the heart, it needs a different medication.
While we take the last comment, Shri, can I request you to start sharing your screen? And can I take a comment on imaging, the imaging protocol quickly in the next 1 minute, briefly? Dr. Priya, would you like to unmute you and then Dr. Mona?
Yes, good evening, Dr. Atul. And
can you increase your audio? Yeah.
Yeah. That was a wonderful case, Dr. Claus. I would like to ask you actually for regarding your acute presentations. So whenever you have a patient with acute stroke, so how do you go about the imaging? Do you I mean, go for the CT or you directly taken, what about the carotid?
We have organized that in our town. First, that the emergency physicians bring the patient only to, or the ambulances bring it only to hospitals where you have a stroke center and this treatment is performed. That's the first point. Then we went to the newspapers and the TV, our local TV, yes, to inform the population. Therefore, in my case, it was the wife of this gentleman, yes, who said, oh, something is amiss, and I called the emergency physician, so they didn't lose time there. That's also important. Then the emergency physician is calling the hospital, so when the ambulance arrives, the neurologist is already at the door. The stroke neurologist, yes, looks at him. And we have already one CT unit free. So the patient goes directly from the ambulance to the CT table, not to lose time. Then we do a native CT, because that will show us, yes, is that already an older infarction, demarcated? Is there cerebral hemorrhage? And you can use this aspect score then to evaluate, yes, the stage of the development of this stroke. Because in the beginning you have only functional loss, but the cells are still alive, even when they don't work. And then we do a CTA, and the CTA should include the aortic arch. So go down not only the brain arteries, but teach your radiologists that you should show everything, because you have to go through the arch later on when you do an intervention. And it's very good to know if there's additional disease, ulcerative atherosclerosis, type 3 aortic arch, and so on. So we have quite a lot of information about the arch, the neck arteries, and the cerebral arteries. When I have that, and in this case, we added also a perfusion scan. That's not always necessary. You can also go on when the time window is very small and there's no other problems, then you can go on immediately. When the patient has arrived at the CT unit, yes, also one entry suite is already prepared. So when the CT is finished, he goes immediately on, accompanied by the neurologist still, to the entry suite. So there's also a team. You need in your hospital at least 3 people, better 4, who can perform the procedure. Yeah. Because it's an emergency around the clock. It's very rare at 3 in the morning, but it can be up to midnight and it can be early in the morning, the so-called wake-up strokes, yes. So that is our concept. And then at the end, the patient goes to the stroke unit and gets a controlled CT a couple of hours later or the next day.
Thank you very much, Klaus. And this was an excellent presentation. We'll have to move forward because we'll otherwise fall behind time. We'll have more discussions, Priya, in the next session.
I think
okay?
I'll take just, I'll talk about the...
I'll come back to you and take your comment later. So thank you so much, Dr. Klaus, and we'll have to move forward. Otherwise, we'll go to midnight over here. Sriram Iyer is ready with his slides. And you will pardon me for interrupting you in between because we are going to keep tight on time also. Thank you very much. Shri, over to you now.
Atul, thank you very much for your very kind invitation to participate in this meeting. Permit me to begin by saying that to help us navigate the complexities of life in general and the challenges that we have all faced as we worked our way through medical school and our residencies and fellowships, we all require the help of mentors and teachers. Professor V.P. Monkar, whom you see on the screen, is a superb teacher and a very talented and skilled clinician who was a neurologist under whose guidance I completed my house post in internal medicine as part of my residency training at the KEM Hospital in Mumbai, which is about 900 miles southwest of New Delhi. And today he's celebrating his 90th birthday. And on this very happy occasion, sir, it is my distinct pleasure and privilege to dedicate and deliver this presentation in your honor. Thank you for helping me overcome the intimidation that neurology can sometimes present and for providing me with the background and the confidence in this specialty, which served me as a solid foundation for my work in carotid stenting years later. Thank you and happy birthday. So let me begin my case by saying we have a 67-year-old right-handed male who presented to us about 4 months after a right hemispheric stroke. He had made a good functional recovery. The history was notable for a prior right carotid endarterectomy, and other than hypertension, which had been, not terribly well managed, no other major medical problems. His carotid ultrasound showed a peak systolic velocity in the right internal about 450 and an end diastolic velocity of about 120. So this is what the angiogram of the right internal carotid shows. You can see almost a hairline 90% stenosis in the right internal carotid, just distal to the bulb. So why did we pick carotid stenting? As you know, post-endarterectomy or restenosis lesions are high surgical risk, amongst other reasons, besides the fact it's a second surgery. The risk of cranial nerve injuries, for instance, is much higher than the 3 to 5% that is quoted for virgin surgeries in the neck. And generally speaking, these kinds of stenoses are considered low risk for carotid stenting. Now, why are they low risk? That's because typically the internal carotid artery is free of any loops or any bends, because as part of the surgery, typically that redundancy is eliminated. Generally speaking, these stenoses are not calcified, and you have a large diameter vessel to work with, usually as a result of a patch endarterectomy. Note, however, there is no effect on the arch anatomy, and in this case, it was, of course, type 2. There is no effect on arch pathology, and that's the reason why we would routinely do all of these procedures with an embolic protection device, because the general thinking is, oh, it's going to be a fibrotic lesion. We don't need any embolic protection. That we beg to differ on that. stance, and we would definitely use embolic protection. And as a carry on from the last discussion, they're dealing with a denervated carotid bulb. So the management of the hemodynamics becomes a very crucial component of the strategy of carotid stenting. So if you look at, this is the pre-angiogram selective left vertebral. You'll see there is no posterior communicating. I can tell you there was no anterior communicating either. And all those small arrows that you see here are leptomeningeal collaterals that are providing some collateral flow to the right hemisphere beyond that tight stenosis. So we have a very tight flow limiting right internal carotid stenosis, no communicating arteries, and leptomeningeal collateral. So the usual procedural steps: 6 French sheath, pre-dilatation of this tight stenosis with a 2 millimeter balloon. That's what we would recommend rather than struggle passing your filter and other equipment through. 6 millimeter emboshial filter, 8 by 10 by 40 exact stent, post-dilated with a 5 millimeter balloon. That's our standard recipe we've been following for many, many years. So the gentleman was 70 kilograms in weight, 70 units per kilogram of heparin. That gave him 5,000 units. As Klaus was saying, we don't give 7,500 or 10,000 as we used to. You have to moderate the anticoagulation. What about the hemodynamics? Well, if you look at the patient with the denervated bulb, heart rate was in the 70s and sinus, blood pressure 160 by 70. Typically, we do not tend to treat these blood pressures. Mean arterial pressure was 85. Atropine was not given because of the carotid endarterectomy situation. And post-dilatation, post 5 millimeter dilatation, no significant change in the heart rate or blood pressure. And in order to bring the blood pressure down, we gave intra-arterial nitroglycerin so that the blood pressure on leaving the lab was around 100, 110 systolic, very similar to what Klaus was saying that we should attempt. So this is a very pleasing picture. We all seen this multiple times. So this was what the patient left the cath lab with. 4 hours post-procedure. Patient complains now of a right frontal headache, 1 episode of vomiting. The neuro exam was non-focal, and this is what the CT of the head showed. You can see there is a pretty clear bleed in the right frontal lobe, some midline shift, but no rupture into the ventricular system. Fortunately for this patient, he never lost consciousness. Usual supportive measures of aspiration precautions, isotonic hydration. We start these patients on anticonvulsants as part of a protocol that we have. Typically, cerebral hyperperfusion, as we'll talk in a few minutes, a generalized seizure is a problem. And fortunately, he made a good, complete functional recovery, and he was sent to rehab. So hyperperfusion simply means the brain has lost its ability to auto-regulate the perfusion pressure in the microcirculation, cephalad to a critical stenosis in the internal carotid artery. So no matter where your systemic pressure is, typically what the microcirculation sees as a result of autoregulation is within a very narrow band, and that is lost in cases of hyperperfusion. It's a recognized complication of both stenting as well as endarterectomy. And of course, even the best embolic protection devices is not going to protect the patient from this particular problem. Now, in terms of terminology, there are 2 things that you need to keep in mind post-reperfusion. One is cerebral hyperperfusion. This does not need to be, and usually not accompanied by any neurological sequelae. It simply means if it's more than 100% increase in the blood flow compared to baseline, that then puts the patient at cerebral hyperperfusion. Cerebral hyperperfusion syndrome, or CHS, that is hyperperfusion with neurological sequelae. So as we said, most often these patients are asymptomatic. Typically what you see is ipsilateral headache of varying severity. Symptoms usually start in the cath lab immediately after procedure, but we have seen it delayed as much as about 3 weeks post-procedure. Usually resolves within 48 to 72 hours. Non-focal exams, occasionally you can see generalized seizures. Injury manifesting as intracranial bleeding, fortunately, is low. It's somewhere between 0.5 to 1%. And these predictors of intracranial bleeding are a severe subocclusive ICA stenosis, extracranial carotid, isolated hemisphere, no ACOM or no PCOM, relies completely for supply on these small wispy leptomeningeal collaterals on the background of hypertension. Our post-endarterectomy case, unfortunately, had all three of these risk factors. As you saw, very severe stenosis, isolated hemisphere, and hypertension. Treatment is mainly supportive. If you need to lower the blood pressure, labetalol or clonidine is recommended because it can reduce also cerebral perfusion pressure. Vasorelaxation increases the cerebral blood flow. So one thing keep in mind is do not use nitrates. We used nitrates here for a combination of things. There was a little bit of spasm, and unknowingly we gave these patients intraarterial nitrates. Anecdotally, they've used corticosteroids, barbiturates, use of mannitol is controversial. So I'll leave you with these management issues. Anticoagulation, what should we use? Should we use heparin? Should we be using something like bivalirudin? Amount we talked about, should we be thinking about reversing the heparin with protamine at the end of the case? What should be the optimal intra and post-procedure hemodynamics? What should be the ideal BP? Because especially the patient has got contralateral disease. If you lower the blood pressure too much, the patient will start having symptoms because of the contralateral hemisphere. So unfortunately, no good answers because fortunately, these problems are rare. But I do want to share with you this case as part of my presentation. Thank you very much for your very kind attention.
That was an excellent case. Actually, so many challenges also. So the basic idea was to first, why did you choose this for a carotid stenting? Would carotid endarterectomy would have been a preferred choice in this case, which you have stated. Let's take an opinion from one of our surgical colleagues, Dr. Yugal Mishra, and then Dr. Rawal Jindal. And then we will come to the discussion on the cerebral hyperperfusion syndrome.
Thanks, Atul, and thanks to Dr. Iyer. I do have one case out of maybe around 400 carotid endarterectomy I performed. One of the patient I do have a same kind of, the post-endarterectomy hyperperfusion. And this was around 10 years back. The gentleman had a very critical carotid stenosis, maybe somewhere 99%. And the question which I'm going to ask Dr. Iyer is, can we predict in a given situation by some investigation to know that this particular patient, because of the criticality of lesion, may land up into the hyperperfusion? So my patients, he had a severe headache, and we did use mannitol, we used steroids, and after 48 hours, his headaches slowly vanished. And after 48 hours, he had a absolutely good recovery. Now here I don't know which kind of patch was put, or this was just eversion endarterectomy. We don't know what was because Dr. Iyer might be knowing, he can throw some light. But if
would you like to address that?
We use a lot vein patch, and in vein patch, the restenosis is very less. Sometimes we get a local elevation formation in very rare cases. So I think I'm interested to know the kind of patch, or this was eversion endarterectomy. Can Dr. Iyer say something about this?
I think if memory serves me right, that this was a reversal endarterectomy. Right. But we also think that part of this may be a clamp injury. Cannot say because it's so long, it's a little distal to the bulb. I do not have the original baseline angiograms to really answer that question. But in terms of the risk, the best predictor where you can really be suspicious that this will happen is if the ipsilateral hemisphere that you're working with has got a low perfusion pressure at baseline, and that is chronic. And that typically occurs with the isolated hemisphere that I was describing on the background of hypertension and a subocclusive stenosis in the carotid. That is the classic setup for a reperfusion problem, whether it will amount to a cerebral hyperperfusion syndrome or whether it will be asymptomatic or generally stop as a headache. That is very, very difficult to predict, at least in my experience now for 25 plus years of doing carotid stenting. Very, very difficult. All we would encourage you all to share with the patients at the end of the case, when you go and talk to the families, we usually say most of the complications are behind us. There is still a small 0.5 to 1% chance that there could be a bleed. The possibility of that is unpredictable, but if 24 to 48 hours goes by and there's not a problem, then we are out of the woods. That's what we typically say.
So one comment from Max Amor. How often, Max, do you see hyperperfusion in patients with unilateral carotid stenosis? Would you like to unmute yourself and address this question?
We have, several years ago, we have studied that problem of hyperperfusion. Because of that, we decided to do CT scan before the angioplasty. We would do it in the 38 hours or 24 hours before the procedure. The reason is that we have noticed that the injection of antivirus medium could create in a hypoperfused brain a hyperperfusion secondary and a bleeding. So we think that a safety measure is really to see the brain by CT scan or MRI before doing the case, because there is always a time delay between the day you diagnose the lesion and the day you perform the angioplasty, and you have silent ischemia or silent infarct that could occur during that period. So I think it is a safety measure really to see the brain before doing a case. And in our hospital, no carotid angioplasty is performed if this examination is not performed. So I think it is absolutely a safety measure. Of course, we have some hyperperfusion, but in different of what you say is that we work with a low pressure because we think that hyperperfusion is favorized by hypertension. So in the reality, we didn't notice so much. And the third thing is that sometimes what is described as hyperperfusion is a showering of emboli that really favorized this kind of evolution. And it's not absolutely hyperperfusion. What you look at the physiopathology of this disease, it is extremely complex, and it is not absolutely certain that what we call hyperperfusion is really noticed. We have an experience of other organs that are not, of course, the brain, but it's not so frequent that it is described. So I must insist that it is imperative to study the brain before doing the angioplasty.
So while Shri, you make the last comment, can I request Dr. V.S. Bedi to share his next presentation? Yes, Shri, over to you.
So one comment for all people and for physicians and interventionists doing the procedure, one of the important things is to keep the amount of contrast minimum during the procedure. Use non-ionic contrast, dilute it 50-50, and use very sparing. We typically don't use more than 20 to 25 ml of contrast for the entire procedure. Because all of this, as Max was rightly saying, we don't know a lot about this problem, but all of this becomes additive, and the less you cause noxious chemicals to go to the brain in the setting of free radicals and injuries-prone parenchyma, the better it is for your patients. Dr. Bedi?
Yeah, excellent. This was an excellent presentation. Thank you so much, Shri. And I invite Dr. V.S. Bedi now to move to his presentation.
Thank you, Shri.
This is now the surgeon's view on what patients, how to choose them for surgical endarterectomy rather than carotid stenting. So there is no confrontation. We have got enough choices for both the surgeons as well as the interventionist. Dr. Bedi is a very accomplished vascular surgeon. Over to you, Dr. Bedi.
Thank you very much, Dr. Atul Mathur, for this opportunity. And we've always enjoyed your meeting every year. Of course, this is the first time that we are doing it on a virtual platform, but we look forward to better times in the following years. And thank you very much. And I think I'm the cat amongst the tigers out here. I'm going to talk about the surgical part, about managing carotid artery stenosis with that one. So this was a patient, this was a patient who presented with 87 years old males, a surgeon of my own hospital who was hypertensive, diabetes and coronary artery disease, had a PTCA about 10 years back, and suddenly started developing recurrent TIAs. A screening duplex showed a bilateral carotid artery stenosis. And then we did a CT angio, which showed a 90% calcified plaque in the left carotid bulb extending into the ICA. There was 60% stenosis on the right side. So this was what the CT angio picture looked like. As you can see these images out here, this was the index side. You can almost see that it is a near total occlusion out here. And again, you find the dense calcification out here. So this is where we were at that particular time. So that considering that he was 87 years, but the only thing is that he was personally is a very fit person. He was driving himself to the hospital every day, coming to work. So whether we should be subjecting him to carotid stenting or carotid endarterectomy. So at that particular stage, the doctor, I don't know what will be the opinion of the panel. Maybe we can ask them a little later what would be their opinion. But this patient went across to the neurointerventionist first, as that was expected. And when the neurointerventionist did a DSA, and this is what he found, once he found this picture, then he was very, very hesitant. And he saw this this plaque out here, which was sitting right in the middle of the internal carotid artery. And he refused that. He said, this is one patient, I would not really touch him with a barge pole. And he sent this patient across to us for a carotid endarterectomy. Because of course, there was no possibility of using any protection system, or with a previous history of TIAs, he was refused an intervention out here. So the management in this case, what we did was, of course, we convinced, and the patient didn't require much of convincing because he was a surgical colleague. It was done under regional analgesia using a cervical plexus block with conscious sedation. Of course, intensive control of blood pressure with nitroglycerine was taken, and the clamp time of 9 minutes, about 32 seconds was there. Intra and post-operative course, he was quite comfortable, no problems at all. And we removed the drains and the lines on the first post-op day, and second day he went home. And just to show that what we do is a different version of the eversion endarterectomy. What we do is a modified eversion endarterectomy. And my friend from Dortmund would remember Dr. Dietrich Reitel, in fact, who described this particular procedure, which is a midway approach to the carotid endarterectomy and eversion endarterectomy, where the arteriotomy extends from the common carotid artery and just proximal to the carotid bulb. So arteriotomy is for a maximum length of about 2 centimeters, as you can see out here. And following arteriotomy, the circumferential plaque from the CCA is lifted and divided proximally, and lifted up and dissected and divided into the ECA. And this is what you're doing. And I'll just show you a small video of this one. And once the plaque is separated with a dissector till it feathers off, the intimal tags are removed, and after ensuring the absence of a flap, primary suturing of the artery is done. So there's no patch. So just now in the previous case, Dr. Yugal Mishra was describing about a patch, and this is what came out of him with a dense plaque out here. The ICA plaque was like this, and this was the ECA plaque. So just to show you a small video out here of modified eversion endarterectomy. So here we are just taking control of the common carotid as well as the other branches. And then we do a limited endarterectomy. And as you can see, there's a lot of soft plaque which is coming out, which is always worrying when we are doing a carotid angioplasty. You will understand that these kind of plaques can be very, very dangerous. So we lift up this plaque, we fracture the plaque, and then we go across and then crush the external carotid artery as we are doing out here, and pull out the plaque from there. And now you can see that now the only plaque which is lifting up is basically the internal carotid artery. At this stage, we loosen the sloop from the internal carotid artery and gently pulling the plaque downwards laterally. You keep on separating out the wall, and that is what you got. You've taken out the plaque completely. You remove all the intimal tags. See that everything else is okay. Don't leave any loose material out here from the external as well as the common and the internal artery. And then after that, with just a primary closure, this is what you do. You got flow restored, you check out the blood flow, you do your de-airing and everything. And this entire procedure is done in about, like I said, about 9 minutes, 32 seconds was the time which was taken for this procedure. And this is the end result out here. So, sorry. So of course, just to share that we have done these about 200 odd patients, and this is still last year data, about 225 odd patients and all. And now we have converted completely into doing patients under regional analgesia, no GA, no nothing. So the chances of complications are less, and we don't use a shunt electively unless and until it is really required. And as I mentioned, that this was the first time it was described in 1989 by Kasperzak and Reichel. Modified diversion endarterectomy is safe and effective, possible under regional analgesia, complete autogenous repair and brief clamp time, plaque extraction through a linear incision, and allows primary closure. And it's easy to convert it for a patch plasty, as Dr. Yugal was describing, where you can put in a patch, whichever one you use in case you have a problem, and you can correct everything out here. The less chances of nerve injury. Technically, it's a much easier and quicker procedure. And the overall complication rate, the restenosis and the perioperative stroke mortality is much lower as compared to the other procedures. This is, of course, the paper that we have published in 2016 of using this technique. And again, just to put in another, if Dr. Atul Mathur will just permit me, sometimes a poorly done carotid stenting can be a problem. And this is one of the patients where there's a soft plaque out here. The interventionist decided to put in a stent, and this patient came back with an occlusion on that particular side, and there's a dense plaque. The stent was completely encased with the plaque material, and I'll just show you here. What we are doing is we are exposing the common carotid. We've done a vertical arteriotomy out here, and gradually we make a plane between the plaque and the wall of the carotid. And on the right side, you can see the internal and the external carotids are swooped out here. So gradually we just keep out, and here this is what we got. Basically, we've got the stent out here along with the plaque coming out, and then gradually we keep on feathering it out. This is going cranially onto the left side. So holding the stent along with gradually dissecting it out, just going around the entire thing. Yeah. So we're just going across into the bifurcation out here. So some background chatter out there with my colleagues, and as it comes out, you can see out here the whole thing is feathered out nicely, and but the entire stent is right now encased with a plaque. So I think what's very important is that you do what is right for the patient, look at the plaque morphology, and then do what is right for the patient rather than just going ahead and doing a procedure just because you have a tool, you want to use that one. So I would say that to me, the current indications for carotid endarterectomy are definitely for a younger patient, definitely merits a carotid endarterectomy. I think most of the panel would agree. A patient with more than 90% stenosis with soft plaque with recurrent TIAs is always going to be a much higher risk for any neurological event. A calcification in the aortic arch, dense calcification with a difficult arch can be a problem. And a hard plaque, like the case which I showed out here, obscuring the IC origin. So you really can't get much of a hardware out there. These would be my patients whom I would subject to carotid endarterectomy. Thank you very much for the opportunity. And thank you, Dr. Mathur.
Thank you so much for these beautiful videos. Very scary to see the carotid stents being explanted. And it's important for the interventionist to see all these. Can I put a question to Sriram Iyer? Would this case of Dr. Bedi, an 80-year-old gentleman with, was it asymptomatic or was it a symptomatic?
He had recurrent TIAs. 87 years old.
Would you consider him with the given anatomy for surgery or for a carotid stenting? And then I'll come to you, Max, for your comment, and then Sri Vallabhaneni. Okay.
Looking at the images of the stenosis with almost circumferential, heavily calcified stenosis, this would not be a case that we would consider for stenting.
Max, what would you say that?
I agree with Shri that it's not an indication of stenting. I respect the indication provided today by Dr. Bedi. In our center, we have refused to do carotid stenting in young patients because we were unable to show a 10 years or 20 years result. Although I always ask permanently this question to my master, Professor Klaus Matthias, how far could we go? And the answer was, he was always very confident on extreme long-term result because he is the father of carotid angioplasty. For myself, I consider that before 60 years old, I think carotid stenting has to be avoided particularly. Of course, the anatomic condition that has intraluminal images, heavy calcification, etc. Although today, and we will publish that in the next 6 months, there is technique to treat extremely calcified bifurcation. But I say, I agree that young patients are not candidates for carotid stenting. Not because it's technically difficult, because we are unable to assure long-term results. Second is that we were always against long stent. The reason we were against long stent is that we consider that if you have a restenosis that you cannot treat, you are going to have a long segment of restenosis that is going to be difficult to treat and sometimes requiring a bypass graft, carotid to carotid. So because we had some cases in the beginning of our experience, I am really opposed to these people where the longer is better. I consider that longer is not better in patient in carotid.
A comment from PK Hazra and then Dr. Ajay Yadav after this.
Excellent case, but we are moving with progress and newer ideas. And if you have IVL, though it is intuitive and provocative, and if you have IVUS, if you have TCDs in Dr. Siram's case or this case, and if you monitor these hits, and if you see the depth of the calcium, length of the calcium, what you see on the angiography may not be the same as we have done from coronary. The calcium may be different on imaging like IVUS. And the IVL, if you use IVL with distal protection or proximal protection or a ticker system like, if you follow IVL plus ticker, I think there will be some scope for this double mesh stent, or though it's a kind of contraindication for heavily calcified to use a double mesh. But things are progressing that we can think of IVL. What you?
Comment from Dr. Ajay Yadav, a comment from you.
I think an excellent demonstration of where the stent would work and where the surgery would work. Being endovascular trained, so we do both angioplasties and surgery, and gives us the benefit of offering the best for the patient. And this particular gentleman, especially with a large eccentric plaque or a thrombus there, I think surgery is still scarce, but patients who are much older, poor heart functions, we still go ahead and do angioplasty.
Stones less than 5 millimeter in size, and then it can tell us about
each one of you has only 2 minutes. So
right, sir. Okay, sir. So this is the genetic test because it is a common cause in form of CFTR mutation, SPINK1 mutation, and PRSS1 mutations. And then some people also go for duodenal aspiration and look for microliths as the cause. So if all these tests come negative, then we label it as true acute recurrent pancreatitis. And then we go for the level 3. And level 3 includes repeat sampling of triglycerides, repeat sampling for calcium levels, and then we can go for pancreatic function tests to look for the exocrine insufficiency in case of early chronic pancreatitis. So this is how we go, sir.
Thank you, but I think nowadays the duodenal intubation for microlithiasis is never done, because after the endoscopic ultrasound, that era is gone. I know the time when we used to be rushing with the tube, Dr. Keshtanen used to make us do that. So Manisha, I'm coming to you now with a very common problem. There's a patient who had 2 attacks or 3 attacks of pancreatitis. His ultrasound shows gallbladder sludge. So what is your protocol? Do you go for cholecystectomy in this situation? Do you give any medication? Do you do repeat imaging? So just be specific and brief.
After taking care of the acute pancreatic episode, by taking care of early nutrition, alleviating the pain and replenishing the volume, the next thing that we do is that if you find such a case who has biliary sludge and has had acute pancreatitis, then the cholecystectomy should be done. Biliary sludge may be innocuous in other situations where we find that if you follow up these patients and 40% biliary sludge disappears, in another 40% it is waxing and waning course, but in 20% it goes on to formation of microlithiasis and gallstones. So here, if the sludge is associated with acute pancreatitis, then cholecystectomy is a must.
I'll come back to Pramod now, because Professor Pramod actually, Pramod, you will have to unmute yourself, actually told us that even microlithiasis, forget the sludge alone, microlithiasis if present, we should be, basing our decision on whether it is biliary or not based on the first 48 hours of abnormal liver functions.
Yes.
And more enzymes elevated, more chances that it is biliary. And then sludge formation could be secondary to, the acute pancreatitis, lack of nutrition, oral nutrition. So, Pramod, what is your take on it?
So this is what I would say, sir, what you have just said, that in the absence of an abnormal LFT, I would be wary of diagnosing biliary pancreatitis. And there's a basic reason for that. Every evidence suggests that it is the stone obstructing the ampulla of Vater that causes pancreatitis, whether it is a reflux of bile into the pancreatic duct or it is the increased pressure of the pancreatic duct, but the cause is obstruction at the ampulla. And all of us have seen at some point that it's stone obstructing the papilla. If that is the case, bile duct gets obstructed. And bile duct gets obstructed, there is abnormal LFT. But if you do not have LFT available, and this sometimes happens, we don't have LFT available in the first 48 hours, then what do you do? So if sludge is persisting, not disappearing, then you can go for cholecystectomy. If most likely sludge will disappear in such a patient.
Thank you. I think that
has to be coupled with a raised ALT more than 3 times the upper limit of normal within 48 hours.
So I think the message, Manisha, will be that we do a repeat imaging if we do not have the LFT and see whether the sludge is persisting or not after the acute track is over. And normally we do it after 3 months and see if the sludge is persisting. Then, of course, cholecystectomy may be with or without EUS. Now, Dr. Chaubal, coming to you with rather similar question. Because everybody is getting an EUS now. So, this is a patient of idiopathic recurrent pancreatitis, acute recurrent pancreatitis. You do an EUS and you find microliths. And now, what is your approach to that?
In such a situation where you definitely have recurrent attacks of acute pancreatitis and you clearly have an etiology, microliths are there, certainly I would recommend, and especially if the LFTs are also delaying the insert 24 to 48 hours. I just faced the situation just 3 days back in a COVID positive female, 32 weeks, having a similar situation, but OTPT were almost 500 distinct with severe pain. She had biliary pancreatitis, very unfortunate female. In such situations, of course, I would definitely recommend cholecystectomy in these situations. And in the meantime, if the person is not ready, and if the cholecystectomy has to be delayed due to some reasons, I may plan to go in for an endoscopic sphincterotomy to tide over that particular process. Or in some situations, you can also start UDCA actually to dissolve those stones.
But so UDCA will take more than a year.
It will take a long time. Yeah, it will.
Also not more than less than 20%. It will be able to do anything.
Yeah. But in a straightforward situation where microliths are there, definitely I would recommend cholecystectomy. If you have clear-cut attacks of recurrent acute pancreatitis, raise LFT at the time of the pain.
Yeah. So, unfortunately, I think Raju cannot join us because he got diagnosed with COVID today. So, we send him our best wishes for early recovery. He was still keen to join, and I'll go to Professor Ramesh Rupray, one of the senior most on the panel. To see, sir, that how frequently do you find hypercalcemia and hypertriglyceridemia as the cause of idiopathic acute recurrent pancreatitis in your practice?
Thank you, Dr. Andir. I believe it is hypertriglyceridemia is only present in 2% to 4% of patients. We also reported a family of 5 persons because primary hyperlipidemia, where it is more than 1,000 or 1,700 or more than that. The family of 5 had all the features of recurrent acute pancreatitis, and this is very rare cause. So we have to investigate these patients when they present first time. And if your lab says it is a very lipemic or it's a very whitish colored serum which is there, always investigate in the first part whenever as you have made the diagnosis of acute pancreatitis with this patient. So hypertriglyceridemia is a common thing, as a very uncommon thing, but we have to keep a watch on this because this could be one of the cause of acute recurrent pancreatitis, and it should be done immediately at the first day. Otherwise, with the
I think we lost your voice, Professor Ruprai. We can't have your audio on. So what Dr. Ramesh Ruprai wanted to say was that hypertriglyceridemia more than 1,000 could be a factor, but not if it is just 300, 400.
Yes,
it is not. Yeah, it is not the causative factor.
This is not the question. And another thing is that hypercalcemia is still less common. In my own clinical practice, I must have seen only 4 patients by now who had acute recurrent pancreatitis, and they had high calcium levels, and parathyroid was one of the cause. And in one of the cases with CRF, we had hypercalcemia. So you should also look for the concomitant diseases which the patient is suffering from, and that also should be kept in mind. So a patient with malignancy, patient with the CRF, where the hypercalcemia is there, that they can have acute recurrent pancreatitis. But again, it is a very, very uncommon disease.
Yeah. Thank you, Dr. Ruprai. I think you made it very clear. In fact, hypercalcemia, the first clue will be that during the acute attack, if you have upper normal limit of calcium or slightly high calcium with properly hydrated patient, you should be investigating them for hypercalcemia when they are recovering, because then there's no sponification and calcium levels will go up. And in fact, contrary to what you said, we have now, we are going to publish it. We have got at least 9 patients of hypercalcemia with recurrent pancreatitis whom we have got operated for parathyroid adenomas. So it's not such an uncommon condition as we used to think if we investigate it. Now, let's see what are the questions from the audience. Anil, do we have time?
Yeah. So I have got some questions. I have noted down. If you have 2 minutes, I can answer them.
Sure, please.
Okay. So the question number 1 was that is tropical pancreatitis seen in South India only? So my answer is there is nothing like tropical pancreatitis. I would refer to a paper in Gut published from AIIMS in 2010 that it is all genetic factors, and we do no more use the term tropical pancreatitis either in South or in North India. Is there a role for endoscopic sphincterotomy? 2 questions to that. And I've shown you enough data that endoscopic sphincterotomy doesn't help in patients with suspected SO dysfunction. One question was that what's the incidence of patient developing chronic pancreatitis? And I've shown data that about 50% might develop if you follow them long enough for about 5 years, chronic pancreatitis. One question was that whether genetic testing should be done or not. And I've said that out of research setting, it probably doesn't help the patients. But nowadays, there is some data emerging that in CFTR mutations, there are some drugs coming in which are being tested in patients with cystic fibrosis. And there is one case report that this compound was used in patients with recurrent pancreatitis. So there is a hope that we might have some molecules directed at specific mutations. But I think for right now, we may not really do it. And one question was related to cola drinks. I don't think we have enough evidence that cola drinks can cause recurrent pancreatitis. But in any case, I think this is something that you should ask your patients to avoid, those who have chronic pancreatitis. And the other question is last one, whether hypertriglyceridemia causes chronic pancreatitis. So most patients present with acute, and there is a possibility they might develop chronic pancreatitis features on imaging as well. Thank you for your attention.
Randir, can I ask a question?
Yes, sir.
Pramod, I want your comment on, the young age group in the days of martial art. They have the blunt injury. They tighten the muscles of the abdomen, and we have seen at least half a dozen of patients from the film industry. They want to build the bodybuilding. And that causes acute edematous pancreatitis, where etiology is all. Your comment on that, Pramod?
So traumatic pancreatitis, sir, is well recognized. We have in fact reported a series from AIIMS also. So, and these patients may have acute pancreatitis, and if once they improve, they may develop a stricture in the duct and causing a distal ductal dilatation, and then they may present with recurrent pancreatitis. So thank you for bringing it up. This is an important cause in children, traumatic pancreatitis. Always ask for that history. Very good.
May I make a comment?
Yeah, Vivek.
Excellent talk and session. Just very quick comments. I think for the genetics, at least as our perspective, that if you have a positive genetic test, it brings closure to the family and the patient and the medical team, and it actually stops the endless search and the cost and the morbidity of additional testing. So there is value in genetic testing if indicated in the right clinical setting. Second point is that in the older population and those who are high risk, either due to syndromic or family history, the role of EUS in recurrent pancreatitis cannot be overemphasized. We have published data on that, and now we're looking at factors in a second study. So cancer is an important etiology. Cancer or pre-malignant lesions are an important etiology, best picked up by EUS, but these patients need follow-up, as Pramod said. They keep coming to the ED. They're older patients. They get sent back. They may not be sent back to your clinic. If you have consulted on them, bring them back, follow them, and they'll have something real in the long term. A couple other things. I think anomalous pancreatico-biliary junction is important to keep in mind. Long common channel is important. These patients do benefit from endoscopic therapy most of the time. But in our practice here, autoimmune pancreatitis is really something that we do start ruling out very quickly once the patient has 2 or 3 attacks. I think it's worth doing it. It's relatively easy. And finally, some of us who are frustrated, and this is across the country here, including big institutions outside of ours, the empiric trial of steroid therapy in those patients who have some subtle hints of autoimmune pancreatitis is being done right now. I don't have any data to support it, but mostly my experience, personal experience, and those of others has been relatively frustrating in that regard. So those are my comments. Thank you for the opportunity.
So thank you, Vivek, for those very nice comments. My only comment with regard to autoimmune pancreatitis is that type 1 autoimmune pancreatitis doesn't really present with pancreatitis. Type 2 autoimmune pancreatitis, which is seen in younger people, males, those who have IBD, may present with clinical acute pancreatitis or recurrent pancreatitis. So that distinction has to be made. And in fact, in India, at least, we're not seeing type 2. We do see type 1, but type 2 is very uncommon here.
That's in Japan mostly. And, the other thing
and also Europe.
As a moderator, I think my role is now to cut short the discussion because Anil is, looking a little restless. So thank you very much. I think we had a wonderful session, and I really appreciate all my panelists, Dr. Banka, Dr. Vivek, for their comments, and thank you very much.
Thank you, Dr. Sood. I am sure all of you would agree that it was a treat to listen to Dr. Sood and Dr. Pramod Garg, and they have given us an excellent discussion and the algorithm as to how to manage recurrent acute pancreatitis, which is a common problem on day-to-day basis. Thank you, Pramod, Dr. Sood, and all the panel members.
Thank you, sir.
With that, we switch on to the second session of the day. And I'm sure on day-to-day practice, incidentally, you find a large number of the patients will come to you with a diagnosis of the pancreatic cyst. Thanks to availability of good quality triple phase CTs, excellent quality, the 3T MRI, and good training by the radiologists, it is not uncommon to have incidentally detected asymptomatic pancreatic cyst. Are they of any relevance? Do they need follow-up, or how do we go about managing them? For the session to be presented, we have Dr. Sandeep Laktakia, who is a well-known figure in field of endosonography in India. He is incidentally also the Secretary General of Society of GI Endoscopy of India. The session will be moderated by Dr. Malay Sharma, who all of you know is one of the pioneers and the doyen of endoscopic ultrasonography in India. So may I request Dr. Sandeep Laktakia to start his presentation, please.
Good evening, sir. Good evening, friends, and it's an honor and pleasure to be here. Thank you, Dr. Arora, for inviting me for this wonderful clinics in hepatobiliary diseases. Am I audible?
Yeah, we can hear you well.
Okay. Can you see my slide?
You have not shared yet. You can see your face.
Okay. How to share here?
Are you on the Zoom mode?
Yes, I am on the Zoom.
Yeah, right in the center, there is a yellow icon with the arrow up called share your screen.
Now
Yeah. Yeah, we can see it. Yes.
Okay. Thank you very much. So, pancreatic cyst advances in management, that's the topic which has been allotted. And when we read about this and face this in a day-to-day practice, they are a very common problem, but each patient is an individual on his own, and we are not sure which way to follow. To sum it up, actually, if I say pancreatic cyst, how to manage, it's really confusing if you see the literature. Having said that, I'll try to decrease the confusion as we come to the talk, and then we can have discussion, and we'll know in the end whether we have actually improved our knowledge or we are still confused. I'll be covering these aspects: the diagnosis, guidelines, surveillance, and surgery. As Dr. Arora had rightly said, these pancreatic cystic lesions are high in prevalence in asymptomatic patients, and seen in about 2.4 to 13.5%. So there are a substantial chunk of normal people who go for imaging for some other reason, and they are found with this lesion. And then they get referred to one of us, and then we have to dissect it out and how to take it forward. These cysts increase with age. So as the population is higher, age-wise, these cysts are detected more. For example, you see patients who are more than 70% who go MRI for some other reason, neurological disorder or age-related issues, about 2 out of 5 will have an incidental pancreatic cyst. But still, if you find that most of the cysts are less than 2 centimeters in size, and that's a good part of it because they do not cause too much of a problem. Cysts which are more than 2 are uncommonly found. Since we have a wide variety of audience in this group, including PGs, there are various types of pancreatic cysts that are classified according to their nature. Pseudocysts being the commonest, serous cystic neoplasm, mucinous cystic neoplasm, IPMN, pseudopapillary epithelial neoplasm. Even neuroendocrine tumors can have cystic degeneration and others. Of these, the most common is a side branch as per literature. The mucinous, IPMN, SPEN, and cystic PNET have a malignant potential. When we say mucin-producing tumors, we basically include mucinous cystic neoplasm and IPMN. SPEN are much more seen, commoner in younger age patients, especially females, and often those cysts which are communicating with the main pancreatic duct are either pseudocyst or IPMN, and they have high amylase in that fluid. So these are the kind of patients that you will see sometimes when they are referred to you. For example, on this image, you see a large cystic lesion in the head with central calcification. Another one on the right side has multiple small cysts all around, but very large in size. And if you do another imaging, if the first imaging is not classical, then you find other features. For example, this is microcystic, very classical of serous cystic neoplasm. On the right panel, you see a cyst with variable size, large and small, with a central calcification. These are classical images to suggest the diagnosis is established by imaging itself. For mucinous cystic neoplasm, another common one, you have large cyst, but the peripheries will be calcified, and there will be no communication with pancreatic duct on imaging. These are the EUS images. I just want to highlight these videos and CTs and other images to audience so that they get sensitized to what is classical and what, when we say, is non-classical. So the left one has a thickened wall with some septae inside. On the right panel is another lesion which will just appear. This is the pancreas. It's on the posterior part of the pancreas with very thick septa inside. The next common one is IPMN, and there are basically two varieties, the main duct and the side branch, and a combination of two is called the mixed variety. The main duct, as the name suggests, the main pancreatic duct gets dilated either segmental or entire extent. And if it's in entire extent, it is dilated, you'll have mucin projecting from the papilla, which can be from the main papilla or from the minor papilla or both, or sometimes even fistulae are created between the pancreatic duct and the GI tract, which is stomach, duodenum, proximal duodenum, or distal duodenum. Side branch IPMN, as the name suggests, arise from the side branches of the main pancreatic duct, and they appear like grapes. They are cysts which are located side by side with intervening normal parenchyma. For example, if you see it here, this is a patient who has a small cystic lesion in the head, which is communicating with the main pancreatic duct here. This is a very small lesion. Whereas on the right panel, you can see a patient who has a dilated pancreatic duct. This is a radial EUS, which is hugely dilated with many hypoechoic lesions within the dilated duct. And these are the mural nodules within the duct. If you compare the MRCP and CT, MRCP and ERCP, these are the appearances. They can have segmental duct dilatation with filling defects, which can sometimes mimic chronic pancreatitis stone. And that's why it has to be differentiated in areas which are endemic like India, or they can be a side branch IPN or a combination of two. Having said all these things, this table tells you that these various lesions on the left panel have certain characteristics which are classical, age-wise, appearance-wise on imaging, and their molecular characteristics. All of them require surgery except serous cystic neoplasm, which has a very low possibility of any malignancy. The rest have variable degree of malignant potential, varying from 20% in MCN and pseudopapillary tumor to 60% in the main pancreatic duct tumor and branch duct about 25%. So do all patients who present with this should undergo surgery? Because that prevents their ultimate improvement. If not, how do we follow them? And that's the part of this talk. Now, this slide tells you a lot of things. From 2005 onwards, there are many guidelines coming from various parts of the world. The ASG guidelines in 2005, the Sendai guidelines in 2006, then we have Fukuoka guidelines in 2012, 17, and 18, and WGO classification in 2019. When you have so many classifications or guidelines coming up in a short period of time of a decade, it tells that things are not very clear. Nobody really knows what is to be done. And that's the sad part of it. We have a reasonable amount of literature. All the quality of studies are not perfect. And that's why this difference of opinion between the various guidelines. So the common 5 guidelines in last 5 years are AGA guidelines, which publish in Reputed Journal of Gastroenterology, the IAP guidelines in Pancreatology, the American College of Radiology in JACR, American College of Gastroenterology in AJG, and European guidelines in gut. So good association, reputed association in reputed journals, but still the final answer for a reader to make an objective interpretation is still difficult. And why is it so? Because the quality of evidence which is used by all these guidelines on which recommendations are made are poor. So if we have a randomized control trial, that's a very good evidence, but most of these studies are retrospective, observer dependent. Having said that, there are some differences also in the different guidelines. The Fukuoka guidelines, which has been modified in 2017, only addresses to IPMN. But it says broadly as the mucinous cystic neoplasm, but it's mainly limited to IPMN. The ACG guidelines cover most of the cystic neoplasm, but they include cysts which are related to the genetic aspects. People who have genetic predisposition to cystic neoplasms and malignancies were excluded in these guidelines. European guidelines are very broad guidelines which take all cysts put together. And if you see this Venn diagram or circle in circle, majority of the cysts are asymptomatic and 1/3 or even lesser are symptomatic, which AGA guidelines take all of them. Also, the European and the Fukuoka guidelines recommend all patients who have symptoms because of the cystic neoplasms, that is either jaundice or pancreatitis, should straight away go for surgery without further investigations. Whereas American College suggests that they should also undergo subsequent EUS and FNA and then have a multidisciplinary group discussion to decide about surgery. So these are finer nuances and which you can use depending on what is available to you and how you interpret these guidelines. For example, this ACG guidelines is quite practical, but if you see the flow chart, it's very confusing. And there's no point spending more time over here in this forum. I'm sure people can read these guidelines and how they follow. So the basic premise of all these guidelines is when and how to assess the risk of pancreatic cystic neoplasms. If the cyst is symptomatic, most are not. In fact, patients start imagining symptoms once they are diagnosed with it. And that's why a good history taking becomes an important issue. But if they come with symptoms and you find this cyst, then they are actually important. Symptom meaning if they have recent jaundice or a pancreatitis which has happened and it is linked to the cyst that they have. In such situation, you can do an EUS with FNA, or you can directly consider a surgical evaluation. But most often the cysts are of this category where they're incidentally found and they often have low risk features. I'll come to this later. And these are the ones which can be either subjected to non-invasive surveillance. As the term says, non-invasive means imaging, which can be in the form of MRI, which is most preferred by most societies. Or it can also be discussed with the patient because everybody has a different understanding and should not cause anxiety among the patient or the physician who's treating them. Then there's a category of cysts which cannot be fitted into any of those that I told in the beginning, and they can be subjected to either invasive surveillance, that means you do an EUS and FNA and make a clear-cut diagnosis that gives reassurance to both patient as well as the doctor who's treating, or you can subject them to non-invasive surveillance at various periods of time. So European guidelines, as I said, considers all pancreatic cystic neoplasms, but they depend on a multidisciplinary approach. What does it mean? It means that it includes a surgeon, a gastroenterologist, a radiologist, oncologist, and so on and so forth, who has a say in that patient. For IPMN, all the guidelines have slight variations. Let's see the European guidelines, which says that cysts which are more than 4 centimeters should be subjected to either surgery, whereas most other guidelines take 3 centimeters as a cutoff. The absolute indications for surgery is a solid mass within the IPMN, presence of a mural nodule, duct which is more than 10 millimeters, and presence of jaundice. And if you have a positive cytology, if you have obtained by EUS guided FNA. How do we survey these patients who have, without any high risk of worrisome features? And you look at this, it's a complex table, but worth a read at leisure, because all this say that the cysts which are small in size, the cysts which are small in size need to have a longer interval of surveillance, whereas cysts which are larger in size, 2 centimeters or more, should have a shorter interval. This is a sum of all these various guidelines. It can vary from 6 months to 1 year, MRI versus CT or alternate, involving EUS in between. That's a little complicated and I don't think it's worth discussing at this forum at this point in time. What are the indications of surgery in suspected serous cyst adenoma? Remember, I told in the beginning, these have less than 1% chance of risk. So all asymptomatic patients should be followed for a year. If there's no growth in size, they can be just left like that. But if this cyst, which can become very large in size and can cause pressure symptoms, or sometimes can cause obstruction to the bile duct or the pancreatic duct, then it may be worthwhile considering surgery because there is a remote possibility of malignancy developing in them. In a large cyst, but a small cyst, 2 or 3 centimeters, classical appearance, one-time diagnosis, and you can reassure yourself and the patient, which would be quite good. ACG guidelines I told earlier, they do not consider, they take all cysts except those who have genetic predominance. So how does one decide which cyst to do what? So balance has to be made. Cysts which have low risk of malignancy, and often they are detected frequently, Also, one should include the cost analysis of surveillance, which is often high. If you keep doing this cyst and evaluation every year for 5 years, or sometimes some guidelines say lifelong, then that has become very costly to the patient if he's paying from his pocket, or even from the insurance agencies who are feeding him, versus the benefit of a cancer prevention. This has not been proven. A very important point of cost benefit versus prevention of cancer. Also, there is no dedicated cost-effective analysis about surveillance of incidental pancreatic cyst. Having said that, you cannot subject all patients of doubtful cystic neoplasm who may be harboring a malignancy also for pancreatic surgery, because risks are also high there. Mortality rate of this incidental pancreatic cyst is about 2%, not very low, and morbidity is 30%, which is quite high. I'm sure most of you must have seen patients who had surgery come with a pancreatic leak or a fistula. Having said that, what imaging techniques should one use to characterize a pancreatic cyst? MRI or MRCP they would have a first imaging by which they come to you, which is often an ultrasound. And then how do you proceed further? I think MRI and MRCP is a test of choice, also recommended by the Radiology Society, because it's non-invasive, there's no radiation, it can be followed up repeatedly, and it accurately tells us whether a cyst is communicating with the pancreatic duct. Having said that, even pancreatic protocol CT, if it is done, is also quite good, and so is EUS. And they're excellent alternatives to each other. In fact, they also match in both sensitivity and specificity. Having said that, sometimes cysts are, in spite of the perfect imaging, will not be diagnosed on one method. And just like we do a second imaging in HCC or hepatocellular cancer, the same analogy is used here, where you do one more imaging. If you have an MRI which is not giving a clear-cut answer, you do a EUS or a CT to find that if two are matching together, then you can say, okay, this is the most likely diagnosis. Or you can follow with an EUS FNA. What is the accuracy of these imaging tests? The caution should be that when you use an imaging to diagnose a cyst or a concomitant malignancy, because they are not foolproof. Most imaging can give you an estimate about 60 to 70% of a diagnosis. So 1/3 of the diagnosis can be missed even in these best of the imagings. For example, the accuracy of MRI, MRCP in diagnosing a cyst is about 40 to 50%. And differentiating from a malignant from benign is also about 55 to 3/4. So not perfect. So both diagnosis and differentiating from malignancy, which is both these information are important. And that's why sometimes rely on the second imaging. And so does the accuracy of CT and EUS. So you cannot diagnose by one imaging perfectly. Okay, so having said that, we need to do further diagnosis to establish a kind of what we are dealing with. But what do we do, or when do we decide not to do any further imaging in a patient, or when to not survey a patient? When a patient is unfit for any surgery. So even if you diagnose a problem, you'll not be taking him for surgery. So why take the effort and cause both anxiety as well unnecessary investigation in these patients, irrespective of the cyst size? And you see here, all these guidelines have strong recommendation. These are experts who are talking about it, but the evidence is very poor. Cyst with very low risk of malignant transformation, example, serous cyst neoplasm, also do not require further treatment and evaluation. So patients who are unfit for surgery and cystic neoplasm of the serous variety need not have further evaluation. What is the role of EUS FNA and cyst fluid analysis? It should be considered if the diagnosis is unclear in the first imaging, or if it is likely to alter your management. Suppose you have decided, okay, I'll take up for surgery, but you do an EUS and find, okay, it's looking classical like a serous cyst adenoma missed by the previous imaging, then the whole scenario changes. More often than not, you can also do a cyst fluid analysis, and CA is the commonest tumor marker which is done. It helps in differentiating the mucinous variety, that is IPMN and MCN, from the other cyst. they usually have a higher value compared to the other type of cystic neoplasm. But the caveat is that very high value doesn't tell you that this patient has a high-grade dysplasia or a cancer harbored in that cystic neoplasm. So the value is not equal to the severity of the illness in a mucinous cystic neoplasm. What about cyst fluid cytology? It has very poor yield. The cellularity of the cyst fluid is very poor, and that's why only 1/3 of the diagnosis can be made through a cyst fluid analysis. However, you can find high-grade dysplasia, especially if you target the mural nodules or a solid component in a cystic neoplasms. Molecular markers are generally in a research protocol, and I leave it there only. The cutoff value that we use for CA is 192, and the pooled sensitivity of this is in 2/3. That means that if you have this value more than 192, the possibility of that lesion being a cystic of this mucinous variety is only 2 out of 3, but the specificity is quite high. And this has been shown in both systematic review and meta-analysis. Mind you, I repeat that the cyst fluid CA does not identify the presence of high-grade dysplasia or cancer in that lesion. Cytology, I told you, has a slow cellularity, about 1/3, and this has been also in IPMNs and MCNs, including the pooled sensitivity is quite poor in many larger series which combine together. So how do we improve the tissue acquisition? There are several devices enumerated here. Cytology brush, where a brush goes through a 19 gauge FNA needle and scrapes the wall of the cyst, and then this brush works like similar to a ERCP brush, but this was led to a lot of adverse events, including pancreatitis and bleeding, and hence it's kind of been withdrawn from the market. The new kid on the block is through the needle microbiopsy forceps, or the More forceps. The preliminary reports suggest it's very exciting. You pass this forceps, it's a micro forceps quite similar to the spy bite, which goes through a 19 gauge needle inside the cyst. Under US guidance, you go to the opposite wall and take a bite out of it. However, we need more studies to say that this is going to make a difference in management or for diagnosis. Cystoscopy is passing a spyglass through the cyst wall and inspecting the cyst from inside. It differentiates serous cyst neoplasm from others and also helps in differentiating IPMN from MCN. Some of the images I'll show you. This is a serous cyst adenoma on cystoscopy, a mucinous cyst adenoma, and these are IPMN with the fish-egg appearance. This is how through the needle biopsy forceps looks like. And another new technology is a confocal laser endomicroscopy, which tells us the real-time histology of the cyst inside. And this probe also passes, a laser probe passes through the 19 gauge needle, and you can touch the opposite wall and get a real-time histology. The next part, which I'll discuss in next few slides, would be cyst ablation, which is considered in patients, since we know that the surgery is high risk, can be high risk, or can have morbidity. Why not do something which is less invasive and still ablate the cyst? And this is the premise by which US guided cyst ablation has been propagated. It obviates the need for surgery. And the two common methods is alcohol installation, which can be in combination with paclitaxel. And mind you, these method of treatment of the cyst neoplasm or local ablation has come from mainly two parts of the world, from Seoul and from US in few dedicated centers. We have them injecting alcohol, withdrawing it, re-injecting, and then finally leaving some paclitaxel in the end. The results are variable, although some centers show that the ultimate cyst resolution is 90% plus over a period of time. But overall, the variable results are 33 to 79%. Adverse event is seen in about 10%, which includes fever, pain, pancreatitis, and peritonitis, including venous thrombosis. RFA has also been tried, although in very small case series. So the debate of cyst ablation is, does cyst decrease in the cyst size after ablation, does it really eradicate the risk of high-grade dysplasia or cancer developing? Most recent studies from Korea say yes, but there are case reports that cancer has progressed And this is an area which is of intense scrutiny world over. Also, if you do an ablation within an IPMN, IPMN, has a field effect and people have a predisposition of a adenocarcinoma developing at separate areas. So just if you ablate the primary lesion, does not take away the need of surveillance. So surveillance has to be carried on because they are still predisposed to adenocarcinoma. So there is insufficient evidence to say that the cyst ablation should be continued. And if it is to be done, it should be done in a research protocol. Let's come back again to cyst surveillance. So which other cysts should be kept under surveillance? It should be in patients who are surgically fit, which means that the cyst is small. If it keeps becoming bigger in size and the patient remains surgically fit, then he can be considered for surgery later on, if not now. But if somebody is surgically unfit, there is no point continuing the surveillance. What is the benefit or survival benefit of the surveillance versus no surveillance? And there are no studies to prove that, because there is relatively low risk of malignancy or low chance of malignancy in all the patients who have this incidentally detected cyst. Even in surgical series who have undergone surgery for incidentally detected cyst, the presence of malignancy or high-grade dysplasia was found in less than 2/5. So that means in 3/5 of the patient or 60% plus patients, you're doing surgery for unknown reasons, which carries higher risk, morbidity, and even remotely mortality. So one has to weigh the risk of surgery and their benefits. Because we also know there are inherent limitations of surveillance. Not everybody can keep coming every year, every 6 months for one imaging or the other. Also, it also depends on the site. If the cyst is located in the head, then the treatment is Whipple's, which carries higher morbidity and mortality, versus a cyst which is located in the tail, where the surgery is relatively easier. So which cysts require increased surveillance or referral to a multidisciplinary group for further? Do I have time, Malay, or I have finished it off? So any patient who has a recent onset worsening of diabetes, just like pancreatic cancers, chances are more. In these patients also, you should start considering that something is happening in them, or the change in size of this cyst. If you have a doubt, you can follow with an EUS FNA as suggested by some of the guidelines. American guidelines suggest that if the patients have symptoms, or the imaging has changed, or if there is a presence of high-grade dysplasia or malignancy on cytology. So these are the indications when you take them for a referral to a center or surgery to be considered. MRCP is the imaging of choice, I told you earlier, because of better contrast resolution, evaluation of main duct communications, presence of septa in the cyst, and even if mural nodules can be picked up, and there is no radiation. EUS matches, but it is invasive comparatively to MRCP. It can be considered in patients who are can be subjected to MRI for a variety of reasons, claustrophobia, or if they have implants in them. It sometimes gives better resolution than a cross-sectional imaging. It has higher sensitivity for differentiating benign from malignant, and FNA is possible and by EUS. When do we stop cyst surveillance? It should be discontinued if the patient is no longer a surgical candidate, and if patient is beyond a certain age. This can be individualized and based on the overall fitness of the patient. The AGA says that the cyst surveillance should stop about 5 years if there is no change in the size and no appearance of the high-risk features. But however, there is insufficient evidence currently to support discontinuation after 5 years. In the end, I would like to conclude by saying that accurate characterization of pancreatic cyst is the key to management. Any high-risk features on imaging, one may consider EUS FNA or subject them to direct surgery. It varies from guidelines to guidelines. Surgical resection should be considered in patients who have high-risk features on imaging, or EUS which is suggestive on imaging or on FNA and the clinical setting. Surveillance is based on the type of the cyst that one is dealing with. the size of it in the beginning and how it changes over a period of time, presence of main pancreatic duct dilation if present, and any other high-risk features like mural nodules and so on and so forth. Surgery, if considered, should be performed at high-volume centers to optimize the outcomes in both terms of morbidity and mortality. Thank you very much for your kind attention.
Yeah, Dr. Malay, you are there? You are.
So that was a fantastic talk, Sandeep. So the only thing is, I would like to ask, there are a lot of people, but how many surgeries, Sandeep, you do in a year for pancreatic cyst?
Well, that's a difficult question you're asking me. I don't have the data from the surgical team, but I would say at least 2 a month is what they would be doing. That's my rough guess, but accurate numbers, I think a surgeon from our team could tell.
The serous cyst adenoma is still just how many you would have operated?
Okay, so that's a very interesting area that you have touched, Malay. I distinctly remember 2 patients in last 10 years who underwent surgery because of cyst, which was very suggestive of serous cyst adenoma on EUS, but they had features of a dilated pancreatic duct upstream to the lesion. And whenever a duct dilates upstream to a lesion, that's a feature of high risk. We learn it from our IPMN guidelines, 5 millimeter or more. But if there's a transition at the cyst level to a higher level, and both these patients who underwent surgery did not have any malignancy, but we got it done in these younger patients who are fit because of this fear of a duct which was dilated. And these were not a long-term follow-up. They were probably 6 months to 1 year of follow-up. The cyst did not change in size, but the caliber of the duct upstream appeared to have become a little wider than before.
One last question from myself before I hand over the mic to other moderators also. How many times have you been proved wrong in your EUS diagnosis by your surgical colleagues?
Quite often, Malay. I must admit that, and this happened more earlier in the earlier phase of my career, but now I am more diplomatic in my answering.
Seasoned.
So I still say that we will not be 100% right. I think I agree with the literature, although I've not objectively analyzed that 2/3 of the time we may be correct, but 1/3 of the time we may be wrong.
Okay. So Vikram, what is your take? You have some questions.
Yes, so I agree with Dr. Sandeep that yes, I was more often wrong previously, but then I think I was more often wrong because I was very categorical about what the cyst was. So I think one has to be humble and express uncertainty that there is a differential. A morphology can never be diagnostic. A cytology can be diagnostic in a small proportion, but a morphology can only narrow the differential unless it is a classical serous cyst adenoma. Having said that, to answer your first question, yes, I have made mistakes also. And at least 3 of my serous cyst adenomas have gone to surgery, but those were misclassifications from my side. So I could not classify properly a macrocystic serous cyst adenoma, mistook or misclassified them as mucinous cystic neoplasms, or was honest enough to say I could not classify them, and then they went to surgery. So we are more cautious when the cyst is in the head of the pancreas, when the implication of surgery is a Whipple's versus a distal pancreatectomy, when we are more liberal. So it is not only how certain we are, it is also how liberal we can be depending upon the location of the cyst and how good or bad the overall condition of the patient is, which dictates who goes for surgery.
Vikram, one more question probably you can answer with. Contrast, probably both of you can answer one by one. Contrast, does it make a difference in evaluation of cyst?
Yes, so good question. Most of my patients now, I would use contrast ultrasound as a routine, and it does add information. I would like to see the enhancement of the septae. As Dr. Sandeep rightfully said, the normal parenchyma between branch duct cysts, so equitable enhancement compared to the normal pancreas in a branch duct. hyper enhancement in a serous cyst adenoma, mural nodules enhancement, and most often we get confused whether this is actually in practice a pseudocyst or a cystic tumor. So let us be honest, even with a good history examination, we often end up confusing a non-malignant or non-epithelial cyst from epithelial cyst, and that is where a enhancement of the wall or the septae sort of gives me confidence, enhancement mainly of the septae, that there is living tissue inside the cyst, and hence this is not a pseudocyst. So I use it almost as a routine now, contrast.
Sandeep, your take on the contrast?
I use it very less, and one, because it's not easily available, it's a little expensive and adds to the, but sometimes, especially in I haven't used too often in cystic neoplasm, but I use it often for PNETs, where if they're doubtful other imaging and tissue diagnosis is not very obvious, because they enhance very well in the arterial phase and they become almost white.
Yes, so even
cystic neoplasm only we use it for when you have doubt of a mural nodule versus a mucin plug, because mural nodules enhance, whereas mucin plug will not enhance, and that will differentiate, and because that's a high risk feature which will be picked up by this.
Yes, so even in a cystic PNET, the wall will often enhance with a contrast, as rightfully said. But then I think that a contrast US in most of the cases would add little or more depending upon what you are looking at. So I am pretty liberal in using it now for a cystic pancreatic tumors.
So we take a balance of the opinion, because though Vikram says categorically he would like to do contrast in almost all cases, and I would agree with him, because this is a very important decision. But there are two problems. Number one is the cost, which I don't think should be a problem, because this is a very important decision for that patient, and sending the patient to surgery is another problem. And the second problem is contrast is not routinely done in many countries, probably in America or in some country. Contrast enhanced ultrasound is not part of the routine yet. So this is, now Sandeep, one more question. Between a nodule, given a chance to do FNAC from a nodule or to tap fluid, would you take the FNAC of a nodule, mural nodule, or you would take fluid?
I will take a nodule first, because that's going to have a more concentrated amount of dysplastic cells, and having punctured through the fluid, I will take the fluid as well. So the first pass goes into the solid nodule, that tissue is aspirated out, and on the way out, you take out as much fluid as possible, which goes for cytology as well.
So first aspirate the fluid and then hit the nodule, or first the nodule, then hit the fluid?
First hit the nodule and then aspirate the fluid.
Vikram, your take?
Absolutely agree with Dr. Sandeep. If I hit a nodule, I've gone through the fluid. So if I aspirate first, I cannot identify exactly very often where the nodule has gone, and to differentiate it from the wall. So through the cyst, I hit the nodule, make a FNA, then a second pass goes in. I've already violated the cyst fluid. So I aspirate it and then aspirate the cyst to dryness. However, if the nodule is large and I can approach it tangentially without going through the fluid, and the nodule is large, I may just go for the nodule itself.
Vikram, positivity of nodule versus fluid?
Nodule is much more. Nodule is by definition the tumorous tissue. So in cyst, it is a hit and chance whether your cytospin will pick up how much the epithelial lining is denuded and how many epithelial malignant cells are floating in this cyst. So it's more of a hit and try. A mural nodule by definition is at least a adenoma, if not an invasive carcinoma. So then you are in the tumor.
In fact, if I can add to that, the cytology yield of the fluid will actually increase after the FNA of the nodule, because some of the cells will get dispersed into that fluid now.
You spill it.
Dr. Kaushal, would you like to add something or ask some more questions, please?
Yeah, so Sandeep, that was a very nice presentation. But for people like me or other community gastroenterologists who don't do EUS, so what would be your message? So if you have a pancreatic cyst, do you require EUS in all, or you can stop at a cross-sectional imaging? Or
That's a very good question.
We refer all patients for EUS?
No, not all patients. So if we have the diagnosis established on the first imaging that we get, and if it's MRI and it shows that the cyst is communicating with the main pancreatic duct, that itself diagnoses it as a side branch IPMN or a mixed variety of an IPMN. Or if the CT, which is more commonly done in India, shows that the calcification of the wall of a cyst, that suggests a mucinous cystic neoplasm, diagnosis gets established, and then we can decide about if surgeons take it directly or if they want further tissue diagnosis, then we take EUS into picture. And the third category is when the diagnosis is not very clear cut. You have a cystic neoplasm and the debate going on between one versus the other, then EUS comes into picture. So indeterminate cyst, EUS adds value. Those which are diagnosed by the first imaging, be it CT or MRI, we can stop there and take a call based on what we have diagnosed.
Thank you.
Malay, can I make a comment?
Yeah, please, please.
Hi, Sandeep, excellent talk. Good discussion. One point about serous cyst adenoma, if they are symptomatic, then we have operated on them. And very occasionally they are symptomatic for one reason or another. Second point is that they also grow. Serous cyst adenomas grow. Growth is concerning sometimes, obviously, but we have re-FNA'd them, but usually the diagnostic yield is very poor in that. But other than that, we stay away from surgery in that group. Malay, you mentioned we are not using contrast EUS or other types of enhanced EUS imaging in America. It's just not caught on. I think there's an additional cost to the EUS apparatus with that. But particularly in the cystic realm, I think solid cystic lesions might benefit from it. Even in the solid lesions, the contrast enhanced imaging is debatable, as Sandeep rightly pointed out. So it hasn't taken on much in the US. And finally, in terms of which patient to go to surgery, I think that's a complex discussion. We have increasingly involved the patient in this shared decision-making model where the cyst characteristics, the serum values for labs, the timeline of the growth of the lesion, all of those factors, the surgical fitness, very appropriately pointed out. And we then finally bring in the patient into the discussion. And most of the times for indeterminate cysts or where the risk is high and the benefit may be low, shared decision-making with the patient is a very valuable tool in this population. Thank you.
I would like to make 2 comments. As Dr. Sandeep said that mistakes are many and they are more in the initial phase of the learning curve. And if there are so many mistakes with the experts like Sandeep and Vikram, I would say that one should be very cautious in, first of all, in diagnosing the pancreatic cyst. I would like to share experience of 2 patients in which the cyst was diagnosed as a pseudocyst and a surgeon attempted a cystogastrostomy and it was a cystic tumor. So these things, they do happen and you have to be very careful, number 1. And number 2, a small thing I have seen that sometimes the lipomas, intrapancreatic lipomas, though they are very rare, I have seen 2. And one of them had a CT appearance of a kind of a cyst because it appeared almost black. So there was a lot of confusion initially, and though later on it was cleared. But what about your experience regarding a lipoma, Dr. Sandeep?
So that is great experience, Dinesh. And Rinkesh, would you like to add anything more to the discussion?
Very nice talk, Dr. Sandeep. I will just ask about the role of EUS elastography of any type of cyst you will recommend, role of elastography. Though it's not required, I know, but any type of cyst.
I think EUS elastography is still a technology which has to find its place. It's available, but what's the benefit of using this? We need much more studies on that. They're more often used in a solid and a hard lesions, that is solid neoplasms versus cystic neoplasms. I think that's the. I think it's not much value at the moment in the cystic neoplasm per se. Dinesh, to answer your question, I haven't seen a lipoma as yet. You have been lucky enough to see in the pancreas.
Maybe
I'm aware that this is a dilemma which occurs in patients who have a black lesion on a CT and on pancreatic protocol CT, which you don't see a cyst on the EUS, and then you get doubtful what was that.
If there are no more questions, may I take this opportunity to thank Dr. Sandeep for his elaborative talk, one of the excellent presentations I've ever heard. Thank you, Malay, for moderating the session very well. And I'm also thankful to all the panel members for having a good discussion on this evolving field of management of pancreatic pseudocyst. And we can appreciate that even if amongst the experts, we are not able to confidently diagnose, look at what happens with us as the beginners. This is the learning phase, and I'm thankful to Dr. Sandeep, panel members, and Malay for taking it forward. Thank you so much. With that, we switch on to the third presentation of the day. This is the management of the common bile duct stricture. So to talk about this complex pathology, I'm sure this is something which we see on day-to-day basis. Patient has jaundice, you get an ultrasound done that shows a CBD narrowing, which could be benign, could be malignant, and could be related to the trauma after surgery. So since this is a complex problem with availability of newer diagnostic modalities like MRCP, CT scan, spyglass cholangioscopy, we do not know how much to go forward in a patient who may have a benign versus malignant disease. To talk on this, we have none other than Professor Nageshwar Reddy, who does not need any introduction. And he's the person who has taken the gastroenterology echelons to the moon for India. And the session will be chaired by and moderated by the flamboyant gastroenterologist from India, Dr. T.S. Chandrasekhar. May I hand over the proceeding to Dr. Chandrasekhar, please? You have to unmute yourself, sir.
Yeah. At the outset, I would like to thank Dr. Anil Arora for his excellent organizational capacity. Is it my audio video clear, Anil?
Yeah, it's all clear, yes.
And I must congratulate at the outset for this excellent webinar program and your team and Sir Gangaram Hospital. We have a very common problem. Unlike what you saw a last speaker telling about nicely about pancreatic cyst. So this is the burning issue every day. Whether it's indeterminate, it's a benign or malignant, what else you will do for this, whether you'll operate or you stent or you will wait for some time. And all these questions will be answered. We have an excellent speaker, Professor D. Nageshwar Reddy. He does not need introduction to any audience, but it's customary to just tell you that he has been the past president of World Endoscopic Organization, and he is the chairman and chief gastroenterologist of the world largest gastroenterology institution. We are very proud to have such institution in India, and he's synonym with the Indian endoscopist. Professor D. Nageshwar Reddy is going to talk on management of biliary stricture. And after that, we have going to have a panel discussion on this. So I welcome Dr. Nageshwar Reddy to start his proceeding. Nagi, you are on, ready.
Thank
you. Can
you.
shoot now.
Thank you very much. Yeah, I think I'm on now. I'd like to thank Anil for giving this opportunity to talk on a topic which is very common in clinical practice. And in recent years, we have developed an algorithm to approach these patients. So what I'll do over the next 15-20 minutes is to try and give a very practical approach of what we do in these patients. So when you're coming with a biliary stricture, a patient comes to you usually with an image saying biliary stricture. First thing you want to see is whether it's benign or malignant. So how do you determine this? And once you determine it's benign or malignant, then you have to decide whether it has to go for endoscopic therapy or surgical therapy. Of course, medical therapy has very little here. And if it's endoscopic therapy, are we going to do a palliative therapy, curative therapy, or increasingly now more new adjuvant therapies? So all these questions have to be answered. Let me show you how we approach this patient. So if you actually look at malignant, or if you look at biliary strictures in general, I have this diagram to make it very simple. We look at proximal strictures, distal strictures. Now, distal strictures are not much of a challenge, so I put everything together, proximal and distal. Proximal strictures, malignant, are usually cholangiocarcinoma, gallbladder carcinoma in the north, whereas distal strictures are usually pancreatic cancers or ampullary cancers. Benign, again, proximal are mostly post-surgical, whereas distal is chronic pancreatitis. So this clear division is very important for us to sort of keep in mind when you're approaching these patients. Now, once we have this division with us, the next thing is that if you actually look at biliary strictures as a whole, you are looking at two types: the non-PSC related, which are most common for us, benign or malignant, versus PSC related. Now, I just put this up because although primary sclerosing cholangitis is not very common with us, we see this occasionally, and then sometimes it's very confusing what to do in this patient. So let's go over first to clear off PSC from our picture and then go further on. For PSC, of course, is quite characteristic appearance on cholangioscopy. Conventional cytology is not very good, but we are now started doing FISH, and when you add FISH, of course, you get a high positivity, both in terms of sensitivity, specificity. The treatment is often balloon dilatation. We do not do stenting, avoid stenting in these patients for this major extrahepatic fistula. So let's get PSC out of the picture and come to the actual problem that we face in clinical practice. These are non-PSC biliary strictures. The first thing is, are they malignant or benign? We have a variety of investigations to approach this. M.I.C.E is a patient usually comes to us to the gastroenterologist with an M.I.C.E picture. Sometimes good CT scans like this, which actually tell us that there's a hilar lesion here with separation of ducts. And of course, an endoscopic ultrasound if it's gone to tertiary centers. Now, even after all this, you'll realize that in many patients, especially for proximal strictures, we still don't have a diagnosis as malignant or benign. For example, look at this. If I show you these 3 X-rays and ask you which is malignant, which is benign, which is inflammatory, I'm sure it wouldn't be very easy to say that. But actually, if you look at it, this was post-operative strictures. The clips are obvious, malignant and inflammatory. Very difficult to distinguish. So this is one of the biggest challenge now in clinical practice for us is this indeterminate biliary stricture. So I'll spend a little time on how we are now making this much more easy to diagnose. The major problem here is the tissue. Tissue is the issue because strictures may look very similar, but this is a cholangiocarcinoma, this is tuberculosis. Still, we continue to see these cases. Could be inflammatory, post-operative, and so on. So the tissue is the main issue here. So in distal biliary strictures, the problem is simplified to a certain extent. An endoscopic ultrasound with FNA, to a very large extent, now up to 80% of the cases, we can get a diagnosis. This is not a problem. So it's more the proximal strictures is a problem. And in these cases, very often we started using cholangioscopy in these patients to try and differentiate benign and malignant. And if you see an obvious picture like this is a cholangiocarcinoma, which is very obvious. So use of this cholangioscope has made it very easy for us. I'll show you a very dramatic experience here of how we can differentiate it. We get 2 strictures here. The high CBD, mid CBD, both of them look like cholangiocarcinoma. All other investigations were normal. And when we did a cholangioscopy, just look at these very interesting pictures. In the left side, this was a high CBD stricture, and you can see a polypoidal lesion here. We took biopsies from this. On the right side, you see a bulge, but you can see caseous material coming out here. And then, of course, it's tuberculosis that's causing this. Biopsies were taken from both, and you can see this was a B-cell lymphoma, which was treated with radiation and chemotherapy, and this was tuberculosis. So both conditions which are gone for surgery, both treated very adequately. So I think this is the power of cholangioscopy in differentiating between benign. And this was the systematic research that was published by Navanithan, and you can see very clearly that cholangioscopy has a very high sensitivity and specificity in patients who have indeterminate biliary strictures. Now, but there is an important thing here to realize that when do you say it's indeterminate biliary strictures? You say indeterminate biliary strictures now. When you do an ERCP, do brushings and cytology, and this is negative, and this is indeterminate. But the concept has changed now. Indeterminate biliary strictures are now termed as indeterminate just at imaging itself. So you have an M.I.C.E, you have an endoscopic ultrasound or a good CT scan. You cannot differentiate to say whether it's malignant or benign. Then we call them indeterminate biliary strictures. So what should we do in these patients? So we actually did this study to see what we can do in these patients. This was a multicentric study with a German and a Hong Kong group. We took 60 patients who on imaging were indeterminate. And then in these patients, divided into 2 groups. One group, an ERCP brushing was done, 29. Another group, directly we went for cholangioscopy. We didn't do ERCP brushing. We went directly for a cholangioscopy and cholangioscopic biopsies. And look at this. The overall sensitivity and accuracy is much higher even in a group when you primarily do cholangioscopy and biopsy, 95%. So therefore, this study very clearly showed that in patient who comes with the indeterminate biliary strictures on imaging, if you, instead of doing multiple ERCPs, if you do a direct cholangioscopy, you would almost 90% of chances get a diagnosis. But there's a problem here in our country. Although this is very good for Western countries, in our country, the cost of cholangioscopy is going to be extremely high. So wherever the ERCP cost is low and cholangioscopy cost is high, this algorithm may not be accurately applicable. But if a patient can afford it, what we suggest is that if we get a patient with indeterminate biliary stricture, instead of doing a ERCP brushing, biopsy, so on and waiting, we do a cholangioscopy. And now we do on-the-spot cholangioscopic biopsy evaluation, so-called ROSE technique. And we have the diagnosis on table so that what you want to do further can be decided at the same ERCP in these patients. So this is one important advance that has occurred recently. Another very important advance that has occurred, and this is very interesting, this is a concept that came in gastroenterology 2 years back, but somehow was missed by most gastroenterologists. We know that malignant tissue actually secretes a large amount of extracellular tissue, extracellular vesicles. These extracellular vesicles are larger in size, more in number in patients who have malignancy. Now, using this, a group from Switzerland actually published a study sometime back in gastroenterology, where they showed that to differentiate between malignant versus benign biliary strictures, all you have to do is take bile from these patients, either putting a nasobiliary tube or a catheter, and then there's a machine, a very simple machine called a nanometer, which you just feed this bile inside, and immediately you can know the amount and the size of the extracellular vesicle. And if there, you can actually very high accuracy to differentiate between benign and malignant. And this was what we published recently, where we looked at these extracellular vesicles with a cutoff point to differentiate between benign and malignant. It was 100% sensitive, a very high accuracy of sensitivity and specificity. Not only this, but when you combine it with volatile organic compounds in the bile, so the bile which we take are then subjected to mass spectroscopy with gas chromatography, and then we can actually, again, with an extremely high value, even in this study was 100% cutoff, by now we can differentiate malignant from benign strictures. And this again has been our experience, which we published recently, where we looked at dichlorobenzene in the bile in patients to differentiate between benign and malignant. And you can see very clearly that the extremely high sensitivity and specificity in differentiating benign from malignant. I think these two technologies, cholangioscopy and using bile for extracellular vesicles and these are volatile compounds, can give us a very clear differentiation. So we are now reaching a rate of about 90 to 95% differentiating benign from malignant. And this vexed question of 30 to 40% of patients with benign going for unnecessary surgeries is no longer there. Okay, so now you've got a patient in whom you're diagnosed malignant biliary stricture. What do you do? Of course, we know that the best hope or cure for this patient is surgery with an R0 resection. Unfortunately, 80% of the patients who come to us cannot undergo surgery because of advanced stage they come. So stenting is what is done as a palliation for most of these patients. So this was the question, what you should do, whether we should do a plastic stent or whether we should do a metal stent. And it used to be thought that for patients who had a short lifespan of more than 3 months, you should put in plastic stents. For those with longer lifespan, we put in a metal stent. But this concept has changed now. And this was a Dutch study which actually looked at all patients, those with even end-stage carcinomas, to see whether you can differentiate whether put a plastic stent or a metal stent. And from this, it's very clear that in all patients, irrespective of whatever stage of malignancy, SEMS may be the best option. Now, if you have a patient who is extremely advanced, has a month or two to live, then of course you don't want to waste your money. But in general, for most patients, we have found that SEMS is superior to plastic stents, especially the cost of SEMS is coming down. Okay, so we now go into the actual management of patients with malignant strictures in the proximal region, so-called patients mainly with cholangiocarcinoma or carcinoma of the gallbladder. So what do you do in these patients? Now, this is, for the ERCP, is the most challenging area, because you have to determine several things. And let me come to these things. That is, what we should know. We should know the Bismuth classification is type 1, type 2, type 3, or type 4. Extremely important. And most often on MRCP, we know this. We should know whether one of the lobe is atrophic, because draining this lobe is not going to be useful. Of course, we look at the vascular involvement, because that makes a difference for surgery, any abdominal anatomy. So before we actually approach these patients, these 4 important questions have to be looked at. In all our patients with proximal biliary strictures, it's almost always a must to do an MRCP. Without an MRCP, we would not do an ERCP in these patients, because this French study very clearly showed that for effective drainage, you have to drain at least 50% of the liver. Now, how do you know 50% of the liver? Of course, based on MRCP and atrophy of the lobe, you can actually calculate whether you're draining 50% of the liver. So this is therefore very important. So once you decide that you know how much liver to drain, what stent should you use? Should you use plastic stent or metal stent for proximal obstruction? I think here it's again very clear from several studies that metal stents are superior to plastic stents. There are many studies, but this is a classic one from Japan, where they compared SEMS with plastic stents in patients with proximal malignant obstruction. It's clear that whether it's cholangiocarcinoma, whether it's nodes, or whether it's gallbladder carcinoma, metal stents are superior to plastic stents. So all these patients, we use uncovered metal stents, but plastic stents occasionally we use in a preoperative setting, the neoadjuvant setting, when the diagnosis is not sure. These are the 2 very rare situations. Otherwise, mostly it's metal stents. Now, how many stents should we use? This is, again, a very common question asked. And this is something which is very important and practical, because if you have a patient, you have to drain 50% of the liver, how many stents should you use? Should you use 2 stents, 3 stents, 1 stent, and so on? Now, this was a very important paper that came from Korea, which actually looked at patients having Klatskin tumor, predominantly type 2, type 3, and type 4. And when they found, what they found was in these patients, when they compared bilateral stenting versus unilateral stenting, they found that bilateral stenting was better because there was less stent occlusion, less reintervention. Although survival didn't differ too much, bilateral stenting was definitely superior to unilateral stenting, especially if you have Klatskin 3B and Klatskin 4. I think it's better to do a bilateral stenting. So, but again, how many stents, which stents? So I've simplified this from several studies in literature, very easy to remember. If you have a patient with Bismuth 1 or Bismuth 2, a single stent is enough. For Bismuth 2, a single stent predominantly in the right side, because 50% of the liver is damaged. If you have Bismuth 3A, again, you put double stent, sometimes 3 stents, 1 in left side and 2 in the right side, because separation occurs between right and left lobe. In Bismuth 3B, again, single stent is enough, because the total left side is cut off. Very often it's atrophic. In Bismuth 4, you have to put 2 stents, usually on the same side, on the right side. So very easy to remember. Bismuth 1, Bismuth 2, and Bismuth 3B, we use a single stent. Whereas in Bismuth 3A or Bismuth 4, we use 2 stents. So this is a very easy formula to remember, especially for the undergraduate, for the postgraduates. And which technique should we use? We know that there are 2 techniques, one side by side and one stent in stent technique. And you can see that of these 2 techniques, I prefer side by side, although many Korean and Japanese endoscopists still do stent in stent techniques, but this doesn't make too much difference. But generally, to summarize, if you have a patient with type 1 endoscopy, type 2 endoscopy, type 3 also endoscopy. In type 4 patients, increasingly now we are taking the help of our interventional radiologists to actually tackle these cases, because type 4, you don't use too much of waste of time for endoscopists to try and selectively cannulate and put in multiple stents. So better to give it off to our interventional radiologist. There's another concept here that we can't reach the ampulla for any region in patients who have biliary strictures, proximal or distal. Then of course you can use endoscopic drainage, ultrasound drainage, either transgastric or transduodenal to drain these patients. This is well established. But what is not well established and what is controversial, what is emerging in the literature is, should we be doing US drainage as a primary drainage? Not because ERCP has failed. You can do an ERCP in these patients, but that some endoscopic ultrasonologists are getting confident in saying, why do ERCP at all? Why not we do US? And 2 studies, one from Shyam Vardarajalu's group published 2 years back showed that US was superior, less pancreatitis. Similarly, another study from Korea, South Korea showed similar features. But I believe we still aren't gone to the stage. I think this is not time to think of primary US drainage for draining biliary strictures. We still have to do ERCP wise. In addition to draining these patients, now increasingly by improving the palliation. How do you improve palliation? Improve survival, increase stent patency, and improve quality of life. And for that, we're doing local tumor ablation. Nowadays, in all our patients and most centers over the world, local tumor ablation is being added to stenting to increase the lifespan and also to increase the quality of life. We reported this long back, about 8 years back, where we started doing radiofrequency ablation in these patients to open up these malignant strictures following stenting. And the first randomized study came from China in 2018, where they showed very clearly that patients who had stent and RFA had a much longer stent patency, much longer survival compared to those who had only a stent. Subsequently, we have had another study from China which showed that if you do RFA, stent plus chemotherapy, you can increase the survival and stent patency in this group. So now it's become fairly common with evidence which is significant that these patients with biliary strictures, in addition to, if you want to just palliate them with stenting, you must add radiofrequency ablation to these patients. So we are done with these now. Most distal strictures, of course, are treated malignant with surgery. Let's come to benign briefly. So benign, you have post-surgical, which are mostly proximal, and distal ones are mostly chronic pancreatitis, and the treatment is different here. For post-surgical or proximal strictures, we do the aggressive approach of Guido Costa Magna using multiple stents. For a stricture like this, less than 1 centimeter post-operative, we put in multiple stents, and after 12 months, remove these stents, and with very good results. So this should be the standard of care. For patients with distal strictures, especially due to chronic pancreatitis, we believe that we should change our practice from multiple plastic stents to a completely covered metal stents. As you showed in the study long back, you can see that 80% of the patients after 12 months and after 3 years are also continuing to have patency of the lumen when you use this. And especially, we recently published this long-term study of more than 5 years, and some of these patients have been followed up to 7, 8 years. You can find that in 60% of the patients, we still have a patency of the lumen after removing the stent, metal stent, which has been put for 12 months. And if you have a pancreatic benign biliary stricture due to chronic pancreatitis, less than 3 centimeters in size, with absence of calcification in the pancreas or a head mass, then in these patients are ideal for putting in this completely covered stent, but you must put it for 12 months, remove it, and majority of the patients can be treated very well with this. Anyway, treatment of biliary stricture, in spite of what all I have said, I think is a multidisciplinary approach. All our patients with the biliary strictures go for a multidisciplinary conference. You have a gastroenterologist, interventional radiologist, surgeon, and oncologist, all coming together, and you'll see that all of them have a role in these patients to give our patients the best care. And to summarize, all biliary strictures, you must have a surgical consult or a multidisciplinary meet to decide what to do. In patients with indeterminate biliary strictures, we are now more often doing a cholangioscopy to get the diagnosis. Distal strictures the US can give, but I think I'd bring your attention to the recent concept of extracellular vesicles or using volatile organic acids to differentiate between benign and malignant strictures. For malignant strictures, especially for palliation, we use self-expanding metal stents, uncovered stents for proximal tumors, along with adjuvant therapy with radiofrequency ablation. For benign strictures, for distal, we use completely covered self-expanding metal stents, and for proximal, we use multiple plastic stents. So using this algorithm approach, majority of the patients with biliary strictures can be treated very adequately on an evidence-based manner. Thank you very much.
Thank you, Dr. Nagi, for your wonderful presentation. This time I really enjoyed it because of your pictorial representation. I must congratulate you for the 2 new publications you had in GI endoscopy. One is on spyglass is better than the ERCP brush cytology. I must congratulate for that. I think we have the panelists lined up, and you have given a overall view of the biliary strictures, both malignant and benign strictures. And I was told by Dr. Anil that a lot of community gastroenterologists and postgraduates are attending. For their benefit, I thought we will take up 5 issues with the other panelists. Let me start with you, Nagi. The concern about cholangitis in proximal biliary stricture when you do spyglass. What is your take on this and how do you prevent it?
Yeah, so this is a very important question. Again, I didn't want to go to too much details of the procedure, but in any proximal strictures, with or without cholangioscopy, the incidence of cholangitis is extremely high. So there are certain precautions. Whenever we do in these cases, we put in a guide wire into all the segments to see that we can enter later on if we want to. And so that suppose the main cause of cholangitis is, of course, undrained segments, which can give rise to this problem. So we have to see that after the cholangioscopy is over, all these segments are drained so that cholangitis is not there. In spite of that, 10 to 15% of the patients develop cholangitis, which may require either a re-intervention or, of course, a percutaneous approach. All these patients are covered with antibiotics before the procedure, so that that is always before cholangioscopy. And the other common trick is that when you're doing cholangioscopy, we try and put in very little saline as possible. The common tendency is to push a button which a lot of fluid flows into that. It distends the bile duct to get good views, but this is not correct. You don't require good views, you require adequate views, adequate to make a diagnosis. And if you follow this principle of not putting in too much saline, very often you can avoid cholangitis in these patients.
So no less saline and still you do it as the best way to avoid cholangitis. Okay. And we have a learned panelist, Dr. Professor S.S. Sharma, Dr. Sandeep Nijaman, and our Barun Srestava, and Dr. Umeed, and Dr. Munish Sachdeva. I have a question. I think Nagi has summarized it very well. But you will always in dilemma when you get a biliary stricture, apart from being benign and malignant, which one will be appropriate imaging while evaluating biliary stricture? You will be tempted to do CT scan, MRI, PET scan, US. Which one you will choose as per the case, or what is your protocol? Professor S.S. Sharma, you are there?
Yes, yes. Sir.
And he's a leading gastroenterologist from Rajasthan and northern part of India. Dr. Sharma?
Thank you, thank you. Once we have seen the level of obstruction on abdominal ultrasound, the next step will be to do either a CT scan or MR with MRCP. Both of these investigations are of equal importance, and some people prefer that for distal lesions, CT scan is better, for proximal lesion, MR is better. But there is no difference. You can choose any of these investigations. Once on CT scan or MR, we see there are the characteristic features of a malignant stricture, or if we see a mass lesion, then the next investigation will be US guided FNA. But depending upon the lesion, the lower, if lesion is in the pancreas or lower CBD, US FNA can be done. Once the lesion is in the hilum and the lesion is resectable or patient is supposed to undergo transplant, in that situation, we do not suggest FNA of that lesion, US FNA of that lesion. A PET scan, as far as PET is concerned, it is uncommonly used, but it can sometimes diagnose the lesion which are not seen on CT scan or MRI, small lesions which are avid for glucose, because there is a high glucose uptake and decreased excretion of the glucose. So one can pick up the lesions, sometimes hilar cholangiocarcinoma, or especially the intrahepatic cholangiocarcinoma and small pancreatic lesions which are not picked up on routine investigations. Endoscopic ultrasound, once if we don't diagnose by all of these lesions, then ERCP guided methods like cytology, biopsy, FIST.
No, we are not going to the tissue diagnosis. First, imaging, I think you are nicely summarized. I think most of the images or imaging techniques are complementary to each other. Yes. So you cannot be with one. If you are lucky, then you'll be all right. And I think you made it very clear. PET scan is only you want to know the extent of the lesion. US if you want to take biopsy. And if it is a lower CBD stricture, the CT scan, the proximal, you want to go for MRCP. Is it all right? This is what. And I just take you to some literature review. The sensitivity of detection of obstruction is good with the ultrasound, CT, and MRI. That's what you said. And you want to know the benign versus malignant. You are more it is CT will be better than the MRI and the ultrasound. But if you want to know the extent of the stricture, as you said rightly, the MRCP would be a better choice of investigation. This is from Radiology 2018. Suppose if you have a case like this, you see the MRCP, and as you rightly put it, you do a US because there was an extraneous impression over the CBD, and we do the FNA like this, and so FNA would be a preference. As you said, you want to take a FNA-C, and this turned out to be histopathology is malignant neoplasm. So this is what it is, you said. And now as you said clearly, the imaging, multimodality imaging we need, and it is a complement to each other. So next issue is, as nicely put it, tissue is the issue in cholangiocarcinoma. So I have another panelist, Dr. Munish Sachdeva. He works in Gangaram Hospital, I was told. Which is your best choice and what is your practical approach? Nagi has told so many the advances happening. I really like that extracellular vesicle he was telling about once in the ACG meeting also, and the fish technique and the spyglass technique. So Dr. Muniz, what is your take? When will you do ERC breast cytology, spyglass cholangioscopy, or US guided or CT guided biopsy? What is your take, Dr. Muniz? Is Dr. Muniz around? Am I audible?
Yeah, Dr. Chandrasekhar, you are.
Yeah, Dr. Muniz. Hi, how are
First
you?
of all,
yeah.
Basically, first of all, I should congratulate Dr. Reddy for his nice and perfect talk. I think he has given everything about the strictures. I should not revise that. You know, if you have ERCP, cholangioscopy, spyglass, and US, so most of the centers, they don't have cholangioscopy and US. I think in that scenario, when you have a high suspicion, when you have a high suspicion of cholangiocarcinoma, especially when you don't have any local lymph node or a distant lymph node, you don't have any liver lesion or a lung lesion, in that scenario, the tissue becomes very, very important in present era of evidence as well as medical legal era. So you have to have a diagnosis, and that diagnosis should be a tissue diagnosis rather than empirically subjecting any patients to treatment suspecting tubercular or a cholangiocarcinoma. So as Dr. Reddy rightly said, in patients who have got lower end stricture, the US with FNB has a very high sensitivity of reaching up to 80%. While in patients with mid or upper stricture, isolated stricture, there is no evidence of any local lymph node or any other lesion behind, then doing a cholangioscopy and biopsy. And I would add on something like, if you have on-site assessment of biopsy with fish or other genetical
you do fish, Dr. Muniz? Do you do fish in your hospital?
Yes, sir. But issue is they are doing only on tissue. They don't give us.
Are you doing this technique called fish in your hospital? Am I audible? Hi.
Yeah, Dr. Chandrasekhar, we don't have fish as yet. I think there is something wrong with the connectivity with Munish. You can carry on.
Okay, right. I think the Nagi has nicely pointed out, but I just want to take you a small literature review here. Brushing alone the sensitivity, see, most of them are highly specific, there's no doubt about that. Brushing alone, 45%, biopsy alone, 48%, but the combination of brushing and biopsy goes up to another 10% more added. So the combination, we have to do that. The other thing, very important thing is if we add fish technique, there is a very important statement. All these three, brush and if you take brush and the cytology, that is biopsy and fish technique, the sensitivity improves to the tune of 80%. That is a very important thing. You see the sensitivity of 82% and specificity. That's the reason was Nagi was emphasizing on fish technique. I think this is how difficult to establish fish technique, Nagi.
Yes. So we have started doing fish now for last 2 years. What we found is Fish is very easy. It's not all difficult to establish. It's just that you have to have a certain volume of cases. The pathologists do this very easily.
But fishing is difficult, no?
Fishing of this fishing, this type of
fishing out
fishing
of that small area is very difficult, no, Nagi?
No, it's the only problem is that what we have found is that specifically fish is useful in the setting of PSC. So if you have a suspected cholangiocarcinoma, in PSC fish is useful. But for regular cholangiocarcinoma, fish is not something that we would be advocating it. And therefore, very small indications, and unless you have volumes, this may not be the right thing to do. But
the cost of establishment, Nagi?
So fish is, no, you do not, cost is not so much because we are using the same technologies in other areas also. The tests in our hospital cost about 2,000 rupees.
Do you accept people referring cases for this?
Yes.
Okay, right. I think that is the important point.
The only thing I want to emphasize is fish is mainly for a setting of PSC plus cholangiocarcinoma versus benign stricture in PSC. That's the place where fish has actually, the group in Mayo started using it first for this, and then that's where it's going to be mainly useful, not for regular cholangiocarcinoma.
It will be very useful in benign or PSC plus or minus cholangiocarcinoma.
Yes,
I think
exactly.
that is the take-home message now. And this is a very important thing. How long you can repeat ERCP biopsy? You don't need to repeat it. If you perform one, if it is negative, and you go for this, a very nice study, and you go for the spyglass cholangoscopy and guided biliary ductal biopsy. This is a very important thing I just want to drive home.
And PSC, I think one important message also we should send out to audience is that never to use ERCP only as a diagnostic modality. ERCP is a very dangerous technique, especially in those with hilar cholangiocarcinoma. The incidence of post-ERCP pancreatitis and infections are extremely high. So one is, of course, one should be sensitized to that. And if you're doing an ERCP, it should also end up as a therapeutic procedure. That is, just do a diagnostic without putting a stent is going to be terrible. So I think ERCP should be approached with a certain respect, both to the patient and to the instrument, I think.
And the instrument, you should never do a diagnostic procedure, should be combined with the stenting. In case in an indeterminate stricture, if the biopsy is negative or breast negative, I think next approach will be the spyglass. This is what it is. So this patient comes with this, the MRCP picture like this. It is acute cholecystitis also this patient had. So they had given us that Murgy syndrome and CBD stricture. And this is the this is a spyglass. Straight away went for the spyglass because of the stricture was whether it's a benign or malignant. We are not able to decide. And the spyglass showed this is the picture. And so what is the panelist thinking? It's a benign stricture or malignant? Nagi had reported naked eye appearance also, very useful. So what is your take, other panelists? Then I'll ask Nagi, what is this? Yeah,
it looked malignant actually because of the vascular pattern was abnormal, and there was a projection of the tissue also, so it looked like malignant.
So the MRCP was very deceptive. Sandeep, Nizaman, you are very right. And this is, in fact, what happened is we did the PET-CT also. It is extreme, widespread, the spread of the tumor, and it turned out to be, then we had to settle with it, and biopsy was suggestive of malignancy. And the same note, I just want to ask Sandeep, this is a MRC picture of one patient, how it looks like. And very important, another small thing, but very important is you must look at the papilla very well. Sometimes lower CBD stricture, papilla gives you a lot of information apart from ampullary growth. So what is your take? Other panelists, I would like to ask Dr. Amit, Dr. Barun, and Sandeep is there, and Dr. Sarmaji.
Papilla looks a bit abnormal actually.
No, this is definitely abnormal. Okay.
Infiltrated. It's infiltrated also.
Infiltrated. Okay. And any guess from other panelists?
I think you see bile coming out from one small.
Bile is small amount of bile. I think Nagi had an extraordinary eye. So this is bile is also coming out. This is abnormal papilla. So what is the guess?
Lower stone.
Stone. That is also very good. Stone. It's like a pregnant ampulla. No.
Carcinoid.
About to develop carcinoid. Vivek, you are there. Good.
Hi.
Hi, Vivek. This is a carcinid, one possibility, impacted stone to second possibility. Third is Nagi is telling small amount of bile is coming out. Maybe, yes. Huh?
I think some fistula formation is there.
Fistula formation also there. Okay. We decided to take a biopsy. And biopsy, there was some bleeding, but so we cut open. Then we took the biopsy, and the biopsy, some bleeding was there. Then the bleeding got controlled with the adrenal injection and this one. And this is the report has come now. Immunohistochemistry had to be done. Most of them are plasma cells positive for IgG4, even though it is little uncommon, very uncommon, maybe rare, consistent IgG4 related. And we reported this case report, and it turned out to be after starting steroid, there is a disappearance of the stricture. Once in a way, you also come across the point here to be learned. You look at the papilla very well in the lower CBD stricture. This is a take-home message. I just want to tell you here. We have Dr. Umid from Nepal. Nagi has told very clearly about. Dr. Umid, are you there?
Yes, I'm here.
And Umid, how is Nepal?
Yeah, it's going on as usual.
Okay, right. Nagi has told very clearly about the benign stricture. Proximal, we go for a multiple plastic stent. Lower end will go for the covered metallic stent, nicely as that. I just want to ask you, there is a time when you need to know about, because this audience, we need to know about this. When do you refer the patient for surgery in benign biliary stricture?
Yes, this is very important because as all of us know that endoscopic therapy is, of course, the first line treatment for the patient with the benign biliary stricture. But there are certain situations where we need to refer the patients for the surgery, even in the benign biliary stricture. So particularly if the patient is non-compliant to endoscopic therapy, there is no option. We have to send the patient for the surgery. But also in the patient with the failure to endoscopic therapy, maybe because of the difficult biliary strictures, then we may have to refer the patient to the surgery. And of course, there is a situation when the endoscopic therapy may be refractory to the benign biliary strictures. Such kind of the things may happen in some of the situations, such as chronic pancreatitis, particularly associated with the calcific pancreatitis involving the head of the pancreas. So if the benign biliary stricture is associated with such kind of the chronic pancreatitis with the pancreatic head calcification, then the endoscopic therapy may tend to be refractory in such cases. So there was one study published in the surgical endoscopy, which has shown that surgical treatment may provide better long-term outcome for the patients in persisting chronic pancreatitis associated biliary stricture, even after the more than 3 times endoscopic procedures. So the study has shown that the chronic pancreatitis associated biliary stricture, particularly associated with the pancreatic head calcificans, may be refractory to endoscopic treatment. So in selected patients,
refractory biliary stricture, particularly also the chronic pancreatitis is the take. Now we have 3 panelists there. Yes, endoscopy, Dr. Nagi and Dr. Sharma and Dr. Sandeep. What is your take on when do you take them for surgery? Nagi, in your unit, how often you refer them for surgery in benign biliary stricture?
Benign biliary stricture is quite easy, again, proximal and distal. Distal strictures are usually secondary to chronic pancreatitis. If the size of the stricture is more than 3 centimeters, if the stricture is associated with the head mass and calcification, these patients better go for surgery, not for endoscopic therapy. Now, for proximal strictures, usually secondary to post-cholecystectomy, sometimes, of course, liver transplant, but post-cholecystectomy strictures, refractory to therapy, not compliant to therapy, or difficult to do endoscopic therapy, 3 indications at once. Or if you want to directly send them for surgery without even endoscopic therapy, is that if the size is more than 1 centimeter, length is more than 1 centimeter, or if the complex strictures involving both the right and left hepatic duct, which are usually ischemic strictures and don't respond to endoscopic therapy. So they're very clear-cut indications when we send our patients for surgery.
So in such cases, you never even attempt endotherapy?
Yes. No, I don't think we should. If it's a complex stricture, ischemic strictures, we should not, because it's going to fail. And what we have found is that for surgeon, It's much easier to operate on a native bile ducts rather than to go and operate on infected bile ducts after repeated stenting. So they don't like it. So therefore, when we have a multidisciplinary meeting, and for example, when GV is sitting and says, okay, this goes for surgery, the patient directly goes for surgery. We don't have to go through endoscopy. I think this is a concept of failed repeated endoscopy going for surgery is not right. We have to decide in the beginning itself which patients are more likely to benefit, because when it's not infected, they do very well post-surgically. But if it's infected, surgical problems post-operative are many.
I think I liked your summary slide that first you said all biliary stricture, you need to have a discussion with the surgeon first. That's a very good statement, number one. Number two is you choose the case right from beginning. Those who really need to undergo surgery, you refer them to surgery instead of now keep on doing the endotherapy. That's very good. Now we have Dr. Barun Shrestha. I just want to ask you, Nagi has really outlined it very well in cholangiocarcinoma inoperable. Do you see any time operable? Because we see aggressive surgeons here, and how do you assess the inoperability, operability? And do you practice double stent? And in type 4, you always go for PTBD or you try ERCP? These are the questions I would like to ask so that we will learn more from our panelists. And Nagi, you can also highlight after Barun says the Shrestha. Dr. Barun Shrestha is there? Dr. Barun is from Nepal.
Dr. Barun, are you there? I think maybe he's not connected.
I just saw him, but there is some connectivity.
As is coming along, this question of type 4, what we should do, endoscopy or PTBD. 20 years back, I would do endoscopy in this patient, go on trying, putting different wires, get some kick out of it, trying to drain. But after a lot of wisdom that has come in, I realized that we should not do. In fact, if I see a type 4, I first ask our radiology colleague, do you think you can tackle it? So if he can, then I'll give it up to him first. I won't even do endoscopy and contaminate this patient. So I would suggest strongly that if you have a type.
Okay, Nagi, I have a small
drainage, because the reason is for radiologists, it's very easy to access different ducts. It's very short route. They can put in multiple stents very easily compared to what endoscopy is done. So it's better if you have a good interventional radiologist, type 4, do not try endoscopic approaches. You contaminate and cause problems, go for radiological approach.
Nagi, I have a small question to clarify here. In endoscopy, we don't inject contrast. We selectively, if the guide wire goes only, we put a stent. Suppose you have a type 4 block, right anterior duct and right posterior duct is blocked. Okay. Now my guide wire goes very nicely to anterior duct, doesn't go to the posterior duct. I don't contaminate the posterior ductal system. I straight away go there. Now in PTBD, they inject a contrast. Sometimes it regurgitate into the posterior duct also. So there is a chance of infecting the other system also, wherein he is not able to put the stent. That is the concern. So what is your take?
Yeah, my take in this first is that when we think we are selectively going to a drug injecting contrast, you don't see contrast to other duct. This does not mean that you're not contaminating the other duct. You are contaminating because some small amount of microscopic connections will be there between the drugs, so you contaminate the drug. Now we see it on X-ray and think, okay, we injected only here, let us drain, we'll drain, but the patient will come back with cholangitis. That's the reason. The reason is because there is some amount of minor communication which the contrast is not seen. Whereas the radiologists, when they inject, they immediately see the communication and they drain all the segments. So that's the reason why radiology, IR is superior to endoscopy in draining these patients. Somebody has asked about air cholangiogram. I personally, of course, air cholangiogram has been described to decrease cholangitis, but I personally would not be doing that because of the problem of air embolism. There are reports of air embolism occur. So be careful, because somebody was suggesting, can we do air cholangiogram? I think you have to be very careful that you should not. We have tried carbon dioxide cholangiograms, which are a little safer, but not so easy to do. So therefore, we still depend on the conventional techniques, but always have a guide wire in the indented duct.
And your slide telling about single stent, double stent, all these things, I think it is very clear about we no need to go into that double stent. 50%. There is always some difficulty in assessing 50% of the volume of the liver. So which is the best technique?
No, if you have a combination of, say, MRCP along with the cross-sectional imaging, either MRI or CT, then it becomes very easy. There are now volumetric ways. In fact, you can do it very objectively also. Our radiologists will tell us exactly. The reason they have developed expertise in this is with the liver transplant coming in, they can exactly calculate the volume of liver that is functioning and so on. We can get very accurate calculations. So there's no problem.
Any opinion from Dr. Sandeep and Sarma about your radiology able to assess volumetric and the assessment of the liver?
We don't do volumetry, but if we see a good dilated ducts in the lobes, if we see that the ducts are nicely dilated in both the lobes, we hope that this portion can be drained very well. If there are irregular thin ducts, we presume that this lobe is atrophied. So volumetry assessment is ideal, but we can assess otherwise clinically also.
Okay. Sandeep, what is your take?
Yeah, actually on CT or MR, you can easily actually have the assessment of the volume. It is very important because at times, you have a dilated duct, but the atrophic lobe is there. So apart from dilated duct, you should have the volume of the parenchyma of the liver, which is important to drain, at least 50%.
Okay, the question to you, I just want to clarify from you is, that I will have your opinion. Do you do liver transplantation in your unit?
No, presently we are not doing, but there are many centers in Jaipur who have started it, and there are few which have been done in Jaipur also in SMS.
Do you think managing post-liver transplant biliary stricture is different from other strictures? So can you highlight on for the sake of the audience?
Yeah, actually, it's a very important biliary complication post-transplant in post-transplant patients. It occurs to the tune of around 5 to 15% in deceased donor, and it gets doubled up in a live donor to 28 to 32%. And it is important because we have two different type of strictures. One is anastomotic stricture, which happens when you do a biliary anastomosis, and the other one is a non-anastomotic stricture. The anastomotic strictures, they appear early. It may appear in days to up to 6 months. And the late anastomotic strictures, non-anastomotic strictures, they appear late, up to 3 to 6 months. And the non-anastomotic strictures are because of the ischemia and some immune pathology also. And anastomotic strictures, they occur because of some technical issues which happen during surgery. And the incidence of anastomotic stricture is to the tune of 13%, which is a little more high, 19% in live donor and 12% in deceased donor. And the difference between the two is like the anastomotic strictures are short, they are single, they are focal, and non-anastomotic, they are ischemic, so they are proximal, they are multiple, and they are longitudinal also, they are long. And MRCP, of course, is as has been discussed, is the modality of choice for evaluating these strictures. And ERCP nowadays in this era is the treatment of choice, and it is very effective up to 90% in patients who have got anastomotic strictures in deceased donor, and it comes to little down around 60-70% in patients with anastomotic strictures in the live donor. But if you have actually non-anastomotic strictures in deceased donor, it is around 50 to 60%, but it still is lower, around 25%.
How it is different? Management part of this.
You see, the management is very much different. A single small stricture, endoscopic treatment is the choice. And in patients who have got multiple long strictures, especially what happens in post liver transplant, the proximal ducts don't get dilated. So it's very difficult to actually dilate these proximal strictures. And the recurrence rate is more, the rejection of the organ is more, and they may need a retransplant, especially in patients who have got a ischemic stricture. So both of them, effectivity wise also, it is different. And they may require actually other modalities like percutaneous transhepatic approach for dealing if the ERCP fails or if there is an altered anatomy. And ultimately, surgery may be required in these difficult strictures.
We found technically a little demanding because after surgery, post-operative additions, other things, and a cadaver transplantation, the stricture is on the lower side, and the live-related one, the stricture is on the proximal side. So, and technically a little more demanding, and you have to be very, very careful not to introduce infection because in the post-operative period. So these are the things we need to take into
TSC in general for post-transplant strictures, multiple plastic stents are better. There are, however, in very refractory strictures, two types of self-expanding metal stents. One is called the moon stent and the other is called the cafe stent. They're very specialized, used only for this type of situation. Although if you have a patient with a living-related transplant, I think you have to be a little more careful because those strictures are more complex. And these strictures require some skill, and sometimes we have to use a spyglass to cannulate the strictures selectively to go in. Otherwise, the guide wire doesn't go in very easily.
Nagi, you said in proximal biliary benign stricture, you will place plastic stent.
Yes, plastic stent.
How about putting like a cafe stent or something like that?
No. We found in cafe you can use rarely those who are resistant, but generally proximal strictures, plastic is better because plastic stents have also got a massage effect there. They're continuously moving in that, and they keep the stricture open much more than a metal. The problem with the metal stent in proximal strictures is that you can't put it equidistant in the center. So either the proximal part is just little above the stent. So the migration is extremely high with this, and the effectiveness of stent dilatation is not so good. So the general easy rule to remember for everybody is for benign strictures, proximal plastic, distal completely covered stent.
Completely. I think in this, we had a fantastic speaker, an excellent panelist. We discussed from the benign to malignant stricture, what is the role of spyglass, and what is the role of extracellular vesicle, and what is the role of twist technique, and the kind of type of stent you need to know, single stent, double stent, all these things are very important. And we just saw a rare case of ampullary, the IgG4 lesion can present like almost like a bulky ampulla, and all these things. This is the highlights of this this session on biliary stricture. I must thank you for the time allotted. We already exceeded 5 minutes, and I must thank you, Nagi, for your wonderful the talk, and panelists Dr. Sharma, Dr. Manish, Dr. Umid, and Dr. Sandeep. We had already highlighted which imaging to be done, what are the efforts to take it to sensitivity to the tune of 90%, specific to the tune of 100%, and don't hang on with the benign biliary stricture. There is a clear-cut case of surgery, and in cholangiocarcinoma, mostly inoperable. So kind of selection of stent to single to double, and the liver transplantation, the strictures, how to manage it effectively. So with this, I conclude this session. Once again, thanking Anil and his team,
Thank you.
Gangaram Hospital, and my panelists and his speaker for this wonderful opportunity. Thank you.
Thank you very much. Thank you.
Thank you, Dr. Chandrasekhar. All of you would agree that we had a wonderful journey from Earth to Moon. And I'm sure nobody would have taken it better than Professor Nageshwar Reddy. And we had a live commentary by the celebrated flamboyant Dr. Chandrasekhar. I'm also thankful to all the panelists for giving their important, useful, practical tips on management of common but difficult problem of CBD stricture. With that, we come to the formal end of this session. We move on to the next session, which is the post-ERCP pancreatitis. All of us as gastroenterologists at some point of time do aspire to do an ERCP because that is something which gives you an edge over others. If I am not mistaken, Dr. Vivek may contradict me that only 10% of the doctors in gastroenterologists in US ever do an ERCP. Since this is a problem associated with significant complication in terms of pancreatitis and bleeding, so not everybody tends to venture into the field of therapeutic endoscopy, especially ERCP. And the most dreaded complication, which is associated with maximum litigation against the gastroenterologists all over the world, that is post-ERCP pancreatitis. We'd like to hear from horse's mouth Dr. Vivek Kaul as to what is new about, he's from Rochester, USA, as to what is new in management of post-ERCP pancreatitis. And the session will be moderated by Professor Ajay Kumar, who is a close friend, my guide and mentor, who has been the ex-president of Society of GI Endoscopy of India and Indian Society of Gastroenterology. Professor Ajay Kumar, please.
Yeah. Thanks, Anil, for giving this wonderful opportunity and a wonderful conference to put together the different experts and the GI people from across the country and abroad. And the topic that has been assigned today to is a post-ERCP pancreatitis, as already mentioned by you, that this is one of the most important issue for the people and the patients, people who are doing ERCP and for patients who are undergoing ERCP. And Nagi used the word while his presentation during the last session that ERCP is a dangerous procedure. For the people, I will just add one line. It's a dangerous procedure for the people who do not require it. With this introduction, and then of course, to introduce our learned speaker, star speaker, Vivek Kaul, dear friend, who is professor of medicine at University of Rochester Medical Center, New York, who is here to talk to us on the subject of post-ERCP pancreatitis. So the pattern is like any other session. We'll have a talk over about 20 minutes from Vivek, and then we go on to a learned panelist to talk about the different to highlight the different issues in the whole issue of post-ERCP pancreatitis. Over to you, Vivek.
Thank you very much, Ajay, and thanks, Dr. Arora and the team, to invite me to speak at this fantastic conference and with all of our esteemed colleagues. Can you guys hear me and see me okay?
Yeah, we can see.
Just raise your voice a little bit. That's it.
All right. I was always told I'm too loud, so I'm trying to be soft-spoken. These are my disclosures. You know, what I've tried to do with these virtual conferences is to put the final slide first. So for those who have to rush to dinner or drinks or are already full of the information, here's the summary version of what I would like to send the take-home message. Post-ERCP pancreatitis is one of the most feared complications of ERCP, potentially life-altering. If it doesn't kill you, it may still maim you. So that's to be kept in mind. The key principles in this realm are to anticipate the pancreatitis in high-risk patients, to mitigate the risk during the procedures, and to manage it in an honest, vigilant, hands-on approach if this occurs. That's really the key principle, especially for the young people diving into this procedure. The ultimate goal in all of pancreatitis, but particularly in procedure-related pancreatitis, is to prevent multi-organ failure, necrosis, and death. The objectives of my presentation today are to harken back to the original definitions a little bit, emphasize the risk factors for this condition, talk a little bit about prevention and management, which is key. And interestingly, there is some new literature in the last 5 years that has emerged in this field, and kind of things are becoming a little clearer, and then summarize with some take-home pearls. ERCP remains, needless to be said, it's already been mentioned a couple of times here, and I second Nagi and Ajay's comments on it being the most dangerous endoscopic procedure. Having said that, we have good solutions for severe bleeding, for perforation, for infection, you know, in the endoscopic realm, but we still don't have a good solution for severe pancreatitis with multi-organ failure. All we can hope is for excellent critical care and God's grace. I would credit Malay Sharma for a couple of these pictures. He and I did a project together on this. This is typical scenarios where you should expect at least moderate degree of pancreatitis. This is a side branch perforation at ERCP. This is the main duct right here. To me, in my experience, and perhaps those of others, this probably, if left unstented, will result in some of the most severe post-procedure pancreatitis states. Here is an acinerization of the pancreas, which is also pretty high risk, and there are studies to show that full contrast injection is worse than only downstream injection. And of course, a beat-up traumatized papilla in a difficult biliary cannulation is something we always fear while the clock is ticking. Now, the reported literature talks about the average rate of post-ERCP pancreatitis to be in the 3 to 5% range, but in high-risk patients, these can go up to 25 to 30%. This is the original definition from Cotton's original paper 20 years ago or 30 years ago now, which says the definition includes abdominal pain, more than threefold elevation of pancreatic enzymes, and hospitalization. Of course, mild, moderate, and severe. And severe, of course, includes ICU admission and death. The revised Atlanta classification is something that we commonly use now. This is more recent, and it actually adds to the abdominal pain, which is the typical pancreatic type of pain, the serum amylase elevations and lipase elevations. It adds the CT scan findings if necessary, although most of the time the clinical diagnosis can be made immediately after ERCP or in the several hours following it. Again, mild, moderate, severe. Severe includes multi-organ failure, SIRS, ICU admission, and interventions. Now, there's a recent study, and I'll try to introduce recent concepts as we go along. And the major charge for me today was to introduce some new studies. So this is a new study from the UEGJ journal. This is actually a great journal for young faculty and fellows to submit papers to. They have a relatively easier acceptance rate. So this paper actually looked at 13,000 plus ERCPs from 8 hospitals and used the consensus criteria and the revised Atlanta criteria to talk about, to look at the sensitivity, specificity, positive predictive value, and negative predictive value. And I can see here as highlighted, the revised Atlanta criteria are a little bit more predictive and should be used consistently. Risk factors for post-ERCP pancreatitis are non-procedural and procedural. The non-procedural ones are listed here. I should say it's a board question, at least in the US, that the prior history of post-ERCP pancreatitis is a red flag, and these patients are amongst the highest. SOD dysfunction has been almost addressed completely, with type 3 being not candidates for this. And always be careful with normal ducts, both biliary and pancreatic ducts, that are higher risk patients. Obviously, the procedural aspects include distal biliary cannulation, acinerization, as I already highlighted, and access sphincterotomy, or the so-called pre-cut sphincterotomy. But this data for access is old data where access was then attempted after, let's say, 30 to 60 minutes. But if you do early pre-cut or early access, those patients do as well as any others. Then there's data around papillary balloon dilatation, which I'll refer to. Sphincter of Oddi I addressed already, multiple contrast injections, and failed clearance of CBD stones. But I think one of the most important criteria are endoscopic training and experience, which is an area that has received a lot of attention in recent years in terms of training and competence. The cumulative effect of these factors is, of course, more significant than each individual factor. So if you are looking at the patient in the clinic or looking at doing the informed consent, look at all these factors in the pre-procedure time frame, and then during the procedure, be aware of these issues. Now, apart from these risk factors, I think the technical issues that lead to a higher risk, of course, include specific conditions such as pancreatic indications and pancreatic endotherapy, ampulectomy, particularly those patients where we have an inability to stent the PD. This is where getting an MRCP before or knowing the pancreatic anatomy before proceeding with the ampulectomy is very, very important. Side branch perforation, I mentioned, and tail perforation. You know, if you have the collimated view on the fluoroscopy, you're not necessarily seeing where the wire is going upstream in the pancreas, so always be aware of that. Almost all patients with inward migration of a pancreatic stent at the index procedure or at repeat procedures when they come to centers like ours for retrieval have developed pancreatitis, and that's to be expected. Transpapillary placement of fully covered metal stents and balloon dilatation are specific, relatively novel risk scenarios, and I'll refer to them in the next couple of slides. So this is a very recent study that looked at the placement of fully covered stents in 600 patients retrospectively. So this is fully covered stent placement in the bile duct leading to pancreatitis, and they found that 9.3% of patients develop pancreatitis, and it was more seen in patients where there was no PD dilatation and if no prophylaxis was given. So their recommendation here was that if you're going to put a fully covered metal stent in the bile duct, consider doing prophylactic PD stenting and be particularly aware of using pharmacoprophylaxis. So this is relatively new information. We have seen this anecdotally and experientially, but now we have a study that shows that this might be a real issue. In terms of endoscopic papillary large balloon dilatation, the current teaching and practice is that you should at least do a small sphincterotomy before placing before doing a balloon dilatation. Otherwise, you can have severe pancreatitis. But here's a study that just came out and was actually reviewed by the ASGE in one of their journal scans. It says here that 19 Japanese centers looked at removal of large bile duct stones with papillary balloon dilatation versus sphincterotomy. All right. So this was papillary balloon dilatation without sphincterotomy, and they found no difference in the rates of pancreatitis. We'll have a discussion on this in our post lecture session. But I found that interesting. I'm not going to change my practice, and do not recommend changing the practice just yet based on one study. But I thought it was important to highlight this. Prevention of post-ERCP pancreatitis is important because we need to look at appropriate patient selection, procedural techniques, and of course, some new literature on pharmacoprevention and fluids, which I'll go through. So there's a guideline document from the ASGE, which has not yet been revised. I think it's due for revision, but here are the take-home points. Appropriate indications for ERCP are probably the most important take-home message today. These are some of the commonly listed indications that are acceptable, and not all of them are listed here, but it gives you the idea. And these are some of the indications that we should stay away from, specifically the first three: abdominal pain, the normal LFTs, dilated pancreatic duct, dilated common bile duct. Especially in the era of MRCP and EUS, there's no reason we should be using ERCP as a diagnostic test. Then there's a few of my other favorites. The surgeon is requesting an ERCP, or the patient is requesting an ERCP. Those are absolute no-nos unless there's a good clinical reason. Type 3 SOD should not be done. And of course, patients presenting with cholecystitis or other forms of gallbladder disease will frequently have some degree of ductal biliary dilatation or some degree of abnormal LFTs. Be very careful that there is a clear indication in these patients for ERCP. In terms of risk mitigation, these are some studies that are a little bit older, but just for historical perspective. It is now well established that guide wire cannulation is the way to go. This is a randomized trial. There are very few randomized trials in endoscopy. Here is one, which saw that equally divided, 150 patients had guide wire assisted cannulation, another 150 had contrast-based and catheter-based cannulation, and the pancreatitis rates were lower in the guide wire group, and all episodes were mild. And here is a meta-analysis which was published a few years ago that looked at 12 randomized controls trials and 3,000 plus patients, where basically they looked at guide wire versus contrast-assisted cannulation, and the relative risk of pancreatitis was significantly reduced, as was the readmission rate. So guide wire assisted cannulation is a very important technical consideration. Now, you know, the concept of pancreatic stenting is obviously something very important and germane to this discussion. I hearken back to Paul Tarnowski's original study here, which was many, many years ago and was Paul's claim to fame in this realm. But more recently, we have additional studies that conclusively prove that in high-risk patients and high-risk clinical scenarios, pancreatic stenting is really impactful in reducing the rate of pancreatitis, as shown on these slides. But also, and I think most experts would agree, even though pancreatitis may occur in this group, the severity of pancreatitis is particularly impacted by stenting. This is another study that I hearken back, a landmark study by my good friend Joel Munzer, who's currently at M.I.C.E. 600 patients published in New England Journal. This was where indomethacin started, and you can see here all post-procedure pancreatitis in the indomethacin group, both moderate and severe, and all pancreatitis were significantly reduced, and this is where indomethacin started. Now, this is a more recent study published in Endoscopy. This is looking at both indomethacin and pancreatic stent versus pancreatic stent alone, pancreatic stent alone. And the group A had PD stenting and pharmacological prophylaxis versus group B had indomethacin alone, excuse me. Total of 414 patients. And this is an important study because it's one of the few and first studies that in a high quality fashion looked at both PD stenting and indomethacin versus indomethacin alone, and they found no significant difference. So it seems like indomethacin really has as maybe a marginal advantage here. We could argue that there's a fewer number of patients here. A larger powered study might bring out a difference, but this was important, I thought, to highlight here in this discussion. Here's another study looking at indomethacin and diclofenac in prevention of post-ERCP pancreatitis. This is a high-quality meta-analysis published in GIE just a couple of years ago. 17 trials, 4,700 patients, and both indomethacin and diclofenac were shown to reduce the relative risk to 0.6, and the number needed to treat was very, very low when compared to other studies in medicine and in GI. So this is something that we should really consider in all patients that are eligible, and it's relatively cheap, relatively easy to do, and a relatively lower number of patients. Again, looking at the efficacy of diclofenac and indomethacin in this review, their conclusion was that patients should receive one or the other depending on the situation and availability, and there is a clear benefit here. Now, another question that has come up is the timing and route of administration. This is a meta-analysis looking at whether it should be given before ERCP or after ERCP, 21 randomized controlled trials, and again, NSAIDs significantly reduced the incidence of post-ERCP pancreatitis. And a corollary here was that indomethacin, when administered after ERCP, seemed to have a more benefit, and diclofenac administered before ERCP tended to have the maximum benefit. These are minor variations on the theme, but as long as you get it into the patient will be better off. Another study here looking at diclofenac with sublingual nitrates. The dosages are mentioned here. Again, the combo group, those that are receiving diclofenac and sublingual nitrate, did much better than the group that received one or the other. And again, the combo group had a significant reduction in moderate to severe post-ERCP pancreatitis. Remember, I keep talking about moderate to severe is where the trouble is. Mild interstitial pancreatitis, it doesn't kill anybody typically. Now, one of the relatively less talked about topics is somatostatin. This is a large multi-center trial published in Endoscopy with 900 patients randomized to somatostatin before ERCP and then after ERCP versus no somatostatin. And even this study found a very significant influence of somatostatin in the treated group in terms of post-ERCP pancreatitis. So maybe more to come on this, but this is not in common use at this time. But I thought it'll be important. It's within 5 years of today's date in terms of publication. Now, all this is great. Pharmacotherapy and pharmacoprophylaxis is great, but occasionally there'll be patients who may not be easily eligible for this or have contraindications. Pregnant patients, certainly, we need to keep in mind. Patients who are allergic to NSAIDs, and obviously be very careful in those patients who are not who are having renal dysfunction, because in a dark room in ERCP on a busy day, you may forget that some patients may have NSAID allergies. Another important area that is being investigated is fluids, aggressive fluids before ERCP, during ERCP, and after ERCP. This is a very elegant study published recently in Endoscopy, about 400 patients, where they looked at different types of fluid resuscitation. So this is aggressive lactated ringers, this is aggressive normal saline, and this is standard lactated ringers, and these are the incidences of post-ERCP pancreatitis. I think the graph speaks for itself. The LR group, which was basically 3 ml per kilogram of LR before, 20 milligram per kilogram bolus, 20 ml per kilogram bolus right after, and then a continuation of the 3 ml per kg after the ERCP did the best, and the numbers are just night and day difference. We have begun to do this to a certain extent, but have not formalized it yet. Again, we can have some discussion on this in the session going forward. Again, this is another study looking at lactated ringers and rectal indomethacin, combination, different groups, normal saline and placebo, normal saline with indomethacin, LR with placebo, and LR with indomethacin. This is the maximum treated group. And again, the graph speaks for itself. The LR with indomethacin group had the maximum advantage in preventing post-ERCP pancreatitis. And most of our patients are getting this in one form or another. And the incidence of readmission was also very low. Now, moving on to the guidelines with that in the background, the ESGE just came out with these recommendations. This is the algorithm for prophylaxis against post-ERCP pancreatitis. So it's relatively simple as algorithms go, certainly more simple than the algorithm that Sandeep had for pancreatic cyst, which I concur with him, is very confusing. So no contraindication to NSAIDs. Basically, everybody gets indomethacin or similar. And if the cannulation is okay, or if there is difficulty anticipated in PD stenting, then you sit tight and give fluids. But if the PD stenting is feasible, go ahead and do the PD stenting. If the patient can't get NSAIDs, then you go over here and you go with fluids. You certainly stent the patient if you can, but you maintain a high degree of fluid resuscitation there. And in those patients who can't get volume, you're really limited and with medication and stenting, and hopefully you can get a stent in these guys. The ASGE has a guideline which is about 3 years old, and it talks about the same parameters that I mentioned earlier in my talk: wire-guided cannulation, early pre-cut sphincterotomy, especially for experts. If you have 10 minutes into the cannulation and you're an expert ERCP, there's something wrong with you, with the day, the mojo is not good, or with the papilla. So you need to consider early pre-cut sphincterotomy if the indication is strong. PD stenting whenever feasible, and especially in high-risk individuals such as ampulectomy, rectal NSAIDs, and LR. So the ASGE, and we all agree, continues to recommend against large balloon dilatation without a pre-existing sphincterotomy. Now, moving on to management, I think this is where it's key. ERCP pancreatitis will occur. The number will never be zero. My personal emphasis here, and that which is reflected in the studies and guidelines, is that you should anticipate the high-risk patients, mitigate the chances of ERCP pancreatitis in the procedure, and manage them very, very aggressively right after. Goal-directed fluid therapy is key, and these caveats, principles, and best practice recommendations are listed in the red box here. IV hydration with LR, that's a preferred solution now. Monitoring of basic hemodynamic and lab parameters, and titrating your treatment accordingly. Pain management and incentive spirometry are very, very important at the bedside. If the patient is having a lot of pain, the respiratory effort is impacted. And I'm a big proponent of incentive spirometry, early ambulation, early feeding, and withholding antibiotics and CAT scan for very specific indications. And the entire goal here is in the first 72 hours, if you avoid multi-organ failure, the patient will likely not die. Antibiotics are not recommended right now unless there are specific indications, and that is a guideline recommendation as well. My personal approach here focuses on indication, a big proponent of indication. I personally review every referral, whether it's inpatient or outpatient. I spend a lot of time myself on informed consent, and I document as such. I look at the procedure time, I look at every step in the procedure, and frequently look at the clock myself as to where I stand in the interventions. And I personally see the patient after the post-procedure in the setting to make sure that my fluid orders, my recommendations, and my personal evaluation of the patient passes the litmus test. So in this particular case, the specific questions are centered around case selection. Is this ERCP really indicated? That's my question to every fellow who comes with the consult. Are there any alternatives that could save the day? Should MRCP or EUS be considered? Are there any specific contraindications to ERCP? And most importantly, what is the patient's reserve for handling complications? And finally, will I be able to defend my decisions in this particular case? These are the caveats around informed consent. It is not just that you have to take the informed consent with the risks and benefits, but the alternatives to the procedure have to be discussed with the patient and documented, and so forth. So these are all the things that have to be documented very clearly, and these will be your best defense both clinically as well as medical legally. There's a lot of things that I've already alluded to in terms of intra-procedural risk reduction, but the details are beyond the scope of this talk. But I think optimizing the biliary axis and approach angle are really key, and a lot of our mentors and teachers from whom we learned ERCP spend a couple of minutes looking at the papilla, optimizing your positioning, minimize frivolous contact with the papilla, use wire-guided cannulation, use contrast judiciously, and all of the things that we talked about already. Post-ERCP recommendations are listed here. And again, my emphasis is to prevent organ failure. ERCP with interstitial pancreatitis will occur at a certain frequency. You really can't get away from that. But have a low threshold for admission. If you did an ERCP and the patient is having pain, don't send them home. Have a low threshold for admission and be hands-on. So summary and take-home points: informed consent and appropriate indication with case selection is really, really key. There is no ERCP for SOD3. abdominal pain, dilated pancreatic duct, and common bile duct. I can't tell you how many referrals I get with pancreatitis that have had ERCP for these indications. Prevention is really the key. You can do a lot of stuff early on before the procedure and in the procedure to make sure that you don't get into trouble. But most importantly, when you do get into trouble, be hands-on and proactive and aggressive with the management. Thank you very much.
Thanks, Vivek, for this an excellent review and sticking to your time and giving the clear carry-home messages. Now, friends, a lot of things have been covered, and a lot of carry-home messages have been given clearly by Vivek. But still, I think we have a wonderful, distinguished panel, panelists here, and we'll take their help to drive home the more important issues and send you the carry-home messages. First of all, let me start with Naresh, dear friend. He's and a neighbor, actually, lives nearby. So Naresh, I like to know, like he has told us that post-ERCP pancreatitis is the most important complication of ERCP. And he's given us the incidences. There are landmark papers from Freeman's group and the Italy group. My question to you, as a practicing ERCP person, do you have the feeling that over the last 5 to 10 years, since we have tried to understood this whole indication better, do you think the incidence is decreasing, or it is same, or it is increasing? And if you think it is decreasing, what is your reasons for why it is happening like that?
Thank you so much, sir. Good evening, everybody, my respected seniors. Thank you, Dr. Ajay, for kind words, and Dr. Vivek for a nice presentation. Sir, I feel post-ERCP pancreatitis is still a nightmare for a gastroenterologist. I feel this post-ERCP pancreatitis and glue are two nightmares still existing in the gastroenterology practice. Yes, sir, the incidence is decreasing, I feel so. And if I see myself 10 years ago, the incidence in our own practice and what we were listening from our friends was quite more than we are observing today. And the basic reason what I feel, sir, that the incidence is decreasing because we have a better understanding of indications of ERCP. We have better MRCPs, we have EUS. For last 5 years, it has been so prevalent and available in centers which we never thought of. These availabilities and better accessories have made better indications for us so that we select cases better than before. More than that, understanding of the treatment or prevention of post-ERCP pancreatitis in terms of available studies and meta-analysis in last 4 or 5 years, particularly. For example, in rectal indomethacin or diclofenac, use of pancreatic stents, better stents. These few factors have made it possible to reduce the incidence.
Thanks, Naresh. Vivek, do you agree with this feeling that in the US also you're feeling the same thing? And,
yes, I agree with that. Thank you. I want to touch wood here and not jinx our experience, but I think the incidence of severe pancreatitis post-ERCP is almost virtually eliminated at expert centers. I still feel that there is a lot of ERCP being done for non-therapeutic indications, which is why I'm actually just submitting 2 papers, one on dilated pancreatic duct and one on dilated CBD, for the express reason that this is still being done in the community and perhaps even at academic centers. And this needs to really go away. But pancreatic stenting has really changed the scenario. And then now with the fluids and pharmacoprophylaxis, there's no reason not to consider that in every patient that's eligible.
So I think the clear message from this is that don't be complacent. The way we talk about COVID, that COVID is coming less severe now or less this thing, but we should not be complacent. Same way here, that if it has come down, it is because of the right indications and right prevention strategy that we are practicing. So we should be encouraging. Still, there is a large number, as Vivek rightly said, there are a large number of diagnostic ERCPs being done across the world, and which should not be encouraged. At the same time, we should be liberal in using the prophylaxis as per the guidelines, not liberal in the sense that we go overboard on that. I think that's the clear message that we should have carry home. Dr. M.I.C.E, leading gastroenterologist from Bareilly. So I like to ask you, see, the Vivek talked to us about the two things, about the various risk factors of post-ERCP pancreatitis. And he did mention in the risk factors, the technique related, talked about the experience of the endoscopist and the difference between the trainee and the endoscopist. Now, I'd like to ask you, which of your patients you will straightway say that should go to started by the consultant rather than by the training? And secondly, how many cases do you think the person should have experience of to label as a experienced endoscopist?
Thank you, sir. As Dr. Vivek has already explained very clearly regarding the risk of post-ERCP pancreatitis, most of the cases within altered anatomy, like post-Biliary surgery or post-transplant surgery, they should be going to the experts. Those patients in which you are suspecting a difficult ERCP will be taking a longer time, and a difficult cannulation should be done by an expert. For youngsters that we are who are starting in ERCP, at least first few ERCP, 100 ERCPs, at least 100 ERCP should be done under guidance, because it takes time for you to understand when how much time you should spend trying the cannulation. Because the longer you manipulate the papilla, the greater will be the chances of pancreatitis and complications in ERCP. So. And those patients who are having oculopathy should also not be dealt in centers who don't have a good backup. These patients should be dealt at better centers.
Right. See, the difficult anatomy is definitely for the experienced endoscopist, not specifically for post-ERCP pancreatitis. Vivek, I would like to, you have put in that very important sidebar that multiple risk factors combined together multiplied the risk of pancreatitis. So if I say, please say that young female not jaundiced with a normal CBD size should be reserved for say the experts right from the beginning. If actually the first is that you should suspect that there is a right indication, and if there's a right indication, it should be reserved for the experts. And second, actually more important thing is, how do you label as a difficult cannulation? There are different definitions, one PD cannulation, second attempt, third attempt, and when do you take up? The first thing is which one you start straight from the expert, and second is if it is not right from the patient related, it is not a high risk, but at what level of technique you will take up from your training of your fellow?
These are very difficult and very important questions. I would like to just say first that, you know, there is a trainee and then there is a trainee, right? So I think in general, I believe that trainees can benefit not just by handling the scope, but just by being in the room. All right. I learned my initial years 25 years ago. I used to go as a first-year fellow, second-year fellow, and join every attending in the hospital was doing ERCP. And then slowly they gave me the duodenoscope, slowly. So that's important for trainees to know, is that just the act of cannulation is not the only time you learn. You learn from the beginning of the consult, in the admitting room, in the post-procedure room, and then rounding in the evening with the attending, even if you have not cannulated. So that's important. Number two is there's a graduated system of assistance where, you know, we watch them, we hold the scope with them, and we even help them cannulate while holding the scope and or the catheter. Number three, there are some very specific cases that really belong at the end of the training or even as junior faculty. For example, altered anatomy, ERCP, ampulectomy, pancreas divisum, and so forth. So the initial trainee has no business actually doing any or more of the part of the procedure. They can certainly learn, And when I take over from the trainee, in general, I'll take over if they're not making any progress for a couple, 3 minutes or 5 minutes, let's say. And then I assist them with that particular step, let's say entering the pylorus, give it back to them. That concept is very important, is that there are some faculty or some practitioners who will take the scope and the trainee never gets the scope. That trainee will never progress. So you take the scope, teach them how to get through a particular step, give the scope back to them, and then watch again. It takes a little bit of patience. I might add that patients, we still do some very few ERCPs with moderate sedation, but I think the level of sedation and controlled environment factors a lot into the ability to teach or not. An anesthetized patient who's under total control, you have enough time, you not have 15 cases lined up, much better situation for the trainee. But the key concept is not to take, but to give back.
Thanks, Vivek, clarifying all these issues and sending a clear message to the delegates. Again, I come back to you with another very important issue. We understand that the prophylactic PD stenting is the SOP today to prevent post-ERCP pancreatitis in high-risk cases. My question is a twofold. One, in spite of this SOP being in practice for a number of years now, what is the practicing habits today? How many people are actually practicing it and how much not? Do you have any data on that? And secondly, you have a patient with a high risk from the patient's characteristics. You have a patient with technically related high risk, but you are not getting deep into the pancreatic duct. I mean, if the patient is just because you are going repeatedly into PD, it's a different issue. How hard you will try to cannulate the PD selectively and put a stent, and where to stop, because that itself can increase the risk of post-ERCP pancreatitis.
Amazing questions. They have been deliberated over the last 10, 15 years since this whole business became common. One of the downsides of the guideline for stenting was that immediately everybody thought that I have to stent. Okay, not just because they're following guidelines, but they felt that if they don't stent, they will be hanged. So I think that's a misconception. It has been clearly discussed that only those cases that are meritorious of pancreatic stenting should be pursued, and not every case needs a PD stent. Marty Freeman addressed this more than 10 years ago at DDW. I think he was asked the same question, and his answer was very simple and humanistic. He said, if you just stop for a moment and you think you should stent this pancreas, and you actually think about it, then please do it. So I think at some level, it's more of an art than a science. But clearly, if you have traumatized the papilla, if you have multiple PD injections, and the patient is a young female, or you just did an ampulectomy, those are imperative situations in which you should really try to stent it. Now, the second part is, how hard should you try? Again, we know that you don't have to stent the entire PD. You just need to bridge the transpapillary barrier. So every unit that is doing ERCPs regularly should have short stents that are flanged, like 5 French 2 centimeter, 5 French 3 centimeter. Your entire goal is to loop the wire potentially in a side branch if you can't get higher, and just get a 5 French 2 centimeter, 5 French 3 centimeter in. That does not take as much time, effort, or trauma as repeated attempts at trying to get into the upstream pancreas. So that's our approach as well, and that's what I suggest.
Great. So now we have see the various prophylactic measures which Vivek mentioned in his talk. The first was a pancreatic duct stenting. Then he talks about NSAID suppositories. He gave some data. Let me ask Dr. Dixit. Dr. Dixit, you all know, is from BHU, the head of the department there, and he's past president of Society of GI Endoscopy, and of course, another dear friend. Dr. Dixit, what is the practice at your center? Are you following the ESD guidelines to use prophylactic suppository in every patient, or are you following ASD guidelines which does not recommend for every patient? I mean, if you are using suppositories, I also want to clarify which suppository, because there is a problem in the availability of indomethacin in India. It's only one company in Hyderabad, in Bangalore, I was told that which manufactures it. At least I've not been able to get it in Delhi, so we have been using diclofenac. I like to have your practical situation.
Sir, we have some problem with the video, but I really enjoyed the talk.
Everybody
of
knows
Dr.
your
Vivek.
face, don't worry. Everybody knows your face.
Are you audible to you? I am
Yes,
audible to
you
you?
are audible.
Okay, sir.
You're audible,
So
sir.
at our center, as you said, though we want to actually stick to the guidelines, so we are only in the high risk cases. Actually, we are giving this prophylactic treatment. As you rightly said, endomethacin supposedly is not available everywhere. So we are not actually getting the virus very occasionally. So we are actually using the dichloromethane sodium, and that too sometimes supposedly is not available. So we are giving just a IV bolus sometime, along with the ringer lactate infusion actually in the only high risk cases. But routine cases when there is a no risk, then we are not using these prophylactic measures like diclofenac or endomethacin supposedly in these patients.
So let me have a just a vote on this for all the panelists who use NSAID suppositories in every patient. Please raise your hands. Dr. Naresh, Dr. Mayank, Dr. Jan, Dr. Of course, Vivek. I know you are following ASD guidelines, not the ESD. Yes,
I follow both.
I am one of those. Our center is using diclofenac suppositories in every patient, and we give it just before starting the procedure. And that's our practice because that's what the ESG recommends. So for us, cost is that these medicines is not much. Of course, we exclude the high-risk patients for the NSAIDs. That's well understood. With this, I move on to the next question to Dr. Jain. Again, very well-known figure across the country among the gastroenterology circles from Bhopal. Dr. Jain, the third modality which has been used is the aggressive hydration. The concept came from the management of acute pancreatitis per se, and now it has come on to the prophylaxis of the post-ERCP pancreatitis. Now, please enlighten us what exactly we mean by aggressive hydration. What is the total fluids? What's the protocol for that? Two, see, there's another issue that there's a large number of patients which come as an outpatients ERCP. So how do we follow in those patients if they require? Do you admit all of them? It becomes a huge challenge in a private sector where the cost factors increase. So I'd like to have your inputs on that.
So good evening, and very nicely delivered the talk by Dr. Paul. That in 2018, a very good publication has shown us that if we'll start the fluid that is ringer lactate better than normal saline, and in our OPD patient of ERCP, which are more patient rather than the indoor patient, because ERCP definitely is a OPD procedure. But as we have discussed in the last half an hour or so, that every patient to be decided whether it is a low risk or a high risk patient. If it is a patient who is having a low risk, in that situation, my policy as a OPD patient in ERCP room is to start the ringer lactate before taking the patient for the procedure. And I will prefer that at least 1 liter of ringer lactate to be utilized during the procedure. And those patients who are being done the procedure very nicely and they are not high risk, in that situation, I will prefer the patient to be observed and the fluid has to be given till he is in hospital. But if the patient is having a high risk case as a patient disease per se, or the procedure which has been done by us, and we know that we had a difficult cannulation, or we have done the wire entry in the pancreatic duct, or we have done the sphincteroplasty or amplectomy. In that situation, it is very clear guideline that I will allow my patient to be in the observation room and roughly 180 ml per hour, that is roughly 1 more liter or maybe 2 liters fluid to be given in the next 4 to 5 hours. And what is my practice is that if the patient is high risk, and we are giving the fluid, and we need to again repeat the assessment of the patient after 4 hours, and the patient is to be observed overnight rather than sending back to the home in the evening. So my practice says that you cannot ask every patient to go home, which you have to discuss in beforehand also and after the procedure, and we have to keep the patient overnight in approximately half of the number, depending on the patient, what indication we are doing the procedure and how was our procedure, whether it is difficult or a very simple procedure. Right. So the fluid intake should be 1 liter to 3 liter depending on patient to patient. Normal saline is not preferred, ringer is better, and if you use indomethacin or diclofenac, as we are using diclofenac, combination of these two will reduce the risk of the pancreatitis.
Thanks, Dr. Jain, for clarifying the issues. Well, friends, we are running short of time. I have to conclude. But before I conclude, I just want to highlight one issue specifically, which I think Vivek mentioned at the end of the talk. Actually, he talked detail about that. That if you look at all the medico-legal issues related to the endoscopic practice, the large number of them, I mean, Peter Cotton wrote some time back on this issue that is the biggest reason for a medico-legal cases. And my brief experience as a member of the ethical committee of the Board of Governors of Medical Council of India, I can say that even in India, that is probably one of the most important cause of the post-ERCP complications being challenged. So in there, we come back to the two things, that proper informed consent, proper selection of cases, and at the end of it, nothing more than works better than two things, that is communication and documentation. Nothing is communicated unless you have documented. Treat the patient, treat the file. Both the things are important. And of course, which Vivek, I think, very beautifully said earlier, that select your patients rightly, and you should be able to defend yourself if you are asked for that why you did that. With that, again, I thank Dr. Anil Arora for giving us this opportunity to all the experts to highlight those issues. And of course, thanks to Vivek for a wonderful talk, and all the panelists for giving the absolutely insight into the whole practice issues. Thank you very much.
Thanks a lot. I enjoyed it.
Unmute, Anil.
Dr. Arora, please unmute yourself. Dr. Arora, please unmute yourself.
Thank you, Ajay, for very well summarizing the excellent presentation made by Dr. Vivek Kaul. I'm sure it was a treat for everybody to listen to the common practice of prevention of acute pancreatitis. As I had already said, this is one of the complications which has a maximum medico-legal complication against any practicing medical fraternity all over the world. With that, I'm sure most of us will be wiser with what we had learned from both of them. With that, I'm also thankful to all the panel members who have joined. And finally, we come to the final session of the day. It may be the last, but not the least. And for presentation, we have none other than Professor Pankaj Pasricha, who was, I'm proud to be his understudy and his colleague at All India Institute of Medical Sciences. He's one of the innovators. Before he starts, let me present to you a quote that there are only two bequests which a mother can hope to give to their children, which are long lasting. And these bequests include roots and the wings. If Dr. Nageshwar Reddy has given us the roots of gastroenterology in India, it is Dr. Pankaj Pasricha who has taken the wings to take the gastroenterology fraternity to unprecedented heights. Beat the discovery of botulinum toxin or the advent of third space endoscopy, he is the innovator par excellence. With that, I'll hand over the proceedings to Dr. Nageshwar Reddy for taking it over.
Thank you, Anil. I think the sharing, okay. Normally in a conference like this, and we're getting, I think, late in time, one does not introduce the speaker at all. Just say that he's going to speak. But I'll take, with the permission of Anil, I'd like to take 2 or 3 minutes.
Yes, sir. It certainly needed.
Pankaj, because Pankaj has an outstanding, very unusual career. And for younger gastroenterologists and students, you require to have an icon who can actually look up to, so that to We require icons in gastroenterology, and unfortunately not many. But Pankaj is an icon whom we should look up to. And that's the reason I thought I'll take 2 or 3 minutes to introduce that. He, after AIMS, he became the chief of gastro at UTMB. Then, of course, Stanford Institute of Medicine, he was a professor of medicine and surgery. And then he finally now is in Johns Hopkins. And look at his positions there. He's the vice chair of medicine for innovation and commercialization. He's the director for neurogastroenterology, and he's a professor of neurosciences in the School of Medicine. I think he's the only gastroenterologist in the world who's also a professor of neurosciences. This is very unique. He's the chair for Center of Gastrointestinal Innovations and Technology of the AGA group, and also is a consistent advisor to FDA on several drug matters. He has several NIH grants, but I think as Anil was telling you earlier, he's not only the botulinum toxin, but the whole third space concept started with Pankaj. In fact, whenever Haro Inovi gives his talk on poems, he starts by acknowledging Pankaj, saying that he was the one who gave him the idea of third space. He holds more than 50 patents, and of course, his innovations are phenomenal. In fact, his main area now, his concentration is on pharmacological therapies for control of glycemia and obesity. In fact, neural control of glycemia is a new concept that is coming up with. And in fact, he's got several awards. I don't want to go into these awards, but he runs, as I said, many NIH programs. He's about 300 papers, several chapters in all the textbooks, Cecil, Hamada, Goodman, Gilman. You go to all the standard textbooks that he's got chapters in that. So I think it's a great privilege this evening to have Pankaj speaking to us. He's, in my opinion, one of the few gastroenterologists who are potential Nobel Prize winners, and to me is a personal hero. Pankaj, thank you very much, and we're eager to listen to what you're going to say.
Thank you, Nagi. What can I say after that? That is very generous. Can you hear me?
Yeah, we can.
I just want to make sure. Very generous, and coming from somebody like you who has a stellar record of achievements in his own right, that is very high praised. So thank you very much. I also want to acknowledge Anil Arora, who has mentioned, was with me at AIMS. He was a year junior to me, and we shared the same hostel building. And I can tell you many stories about him, but maybe some other night. But it is also a source of great pride to watch him achieve what he has, and acquire the kind of national and international reputation. And then, of course, Ajay, who's a dear friend of mine, who's moderating the previous sessions. Always good to see you. But I wanted to dedicate this talk to Dr. Rakesh Tandon, who, as you all know, sadly passed away recently, and was a mentor for many of us, directly or indirectly. He was a scholar and a gentleman. He was there when I was a student at AIMS, but throughout my career, I always found him listening to my talks at DDW or some other forum, and he would come up to me and congratulate me and give me encouragement. So I think I'll miss him today. I'll miss his presence today after this talk, but I hope you'll join me in wishing his soul and his family all the peace and joy. Thank you. So Anil had originally asked me to talk about, I guess, the future of endoscopy and innovations that may be emerging. As if anything, the COVID crisis has taught us that it's almost impossible to predict 3 months from now, let alone a few years from now. Since that is the case, I thought I would rather spend my time not talking so much about specific ways that the future will change, but rather how I learned about the ability to come up with innovative ideas and perhaps, and I say this with all modesty, change the future. So it's not so much about what the specific embodiments are, it's really the process by which you think of those embodiments. So if you'll indulge me, I'll spend a few minutes talking to you about that. So let me go to slideshow. Can you see the full slide, or is it on a slide?
We can see the full slide.
Okay, good. So what are the principles of effective innovation and how to integrate them in your practice is what I'll spend the first half of this talk about. As we are very familiar, and as we have seen in some of the talks today, the current paradigm, and this applies to not just GI innovation, but medical innovation in general, we start with a solution, as an example from the previous talk, and Vivek gave a wonderful talk, and I congratulate him on it, but we start with a solution. Let's start with octreotide as an example, or start with a pancreatic stent, and let's figure out now what the problem is. So if the problem is post-ERCP pancreatitis, let's try to put it in place and see if it works. And we do that. Sometimes it works, sometimes it doesn't. We get into, some clinical trials, validation, but then we say, we're ready to go to market. And when we go to market, we realize that many of the steps that we needed to take were missing in this formulation. And therefore, we've not only spent a lot of time and resources, but we may never be successful. This is a lesson I learned very, very early on. And I want to tell you about some of the steps you can take to avoid that. But the key to innovation is not the solution. This is a very important concept, and I'll keep trying to emphasize this. The key to innovation is finding the real need, filtering it, refining it. And if you don't do that, then any solution that you bring forth will be unlikely to succeed. I'll give you some examples of that. And again, just before I get into that, need finding does not simply mean asking questions, asking your colleagues, asking your patients, asking your collaborators in the industry. Henry Ford's famous quote, if I'd listened to my customers, I'd have given them a faster horse, because at that time, that was what people were doing, just riding around on horses. Finding a need is really about an unbiased approach to solving the problem. And if you don't go through the very rigorous intellectual exercise about formulating the need statement, then your innovation may not succeed. This is like finding the genetic code, as Tom Crummell, my colleague at Stanford, often says. And I'll give you an example. You can come up with a need statement. 30 years ago, people said, I want a better method to do coronary artery bypass grafting. That need statement is, as far as I'm concerned, pretty useless. It doesn't give you a way forward. It doesn't tell you what the right solution should be. A better need statement is a better method to revascularize the heart. And if you came up with that need statement, as Andreas Gunsig did, he came up with the concept of balloon angioplasty, first in the peripheral arteries, and then of course it was applied to the coronaries. So he didn't want to sort of say, let me figure out a less invasive way to do the exact same thing, which was bypass. But what he wanted to do was get to the heart of the problem, which is, heart of the problem is ischemia. How do I revascularize it? Having done that, he opened his mind up to all kinds of possible solutions.
Pankaj, sorry to interrupt. Can you do a slideshow so that the whole slide is seen? We're seeing part
Yeah,
of
that's
it.
what I was asking. I don't.
Yeah. Can you do a slideshow?
Is that better?
Yeah, now it's better.
Thank you, sir.
Okay. So what I was saying was the need statement here was how to revascularize, not how to do better bypass. We fall into that trap a lot. I'll give you another example. When I was at Stanford, so we ran this biodesign program at Stanford, very talented team of trainees as well as people from industry. And many of you have gone through this exercise of doing a lumbar puncture. And it was clear that there were problems with leakage happening very, very frequently. And if you did a survey and you just talk to doctors who did this, they say, well, there's a need for a better method to perform lumbar puncture. Again, this need statement is pretty useless. Yes, that's obvious, but it doesn't really get to where the right solution is. So this team of trainees in the biodesign program went through this exercise, filtered the need statement, refined it, and came up with the need is a better way to control access to the epidural space. Now, with that need, clearly stated, they came up with the right solution. And it is the simplest of all solutions. It was simply a screwdriver instead of a straight needle. Because the engineers on that team said, look, you want to have control access, we can do this with a screwdriver. Because with each turn of the screw, we advance incrementally as opposed to try to push a needle through. And so they actually came up with this design for a screwdriver bevel for the epidural space, and they were able to reduce the complications. And now this is a commercially available device. It's called Epiphany. Other examples, from sort of our own work here at Hopkins, you know the story about type 2 diabetes, medicine, surgery, gastric bypass is the big solution now for type 2 diabetes. And what does it do? It bypasses a critical part of the duodenum. So you could come up with a need statement that says, I want to do gastric bypass better, laparoscopically, for instance, which is now being done, or I want to do it endoscopically, some way to create an anastomosis. But really, the need statement was, the correct need statement was, how to better exclude the duodenum from coming in contact with the luminal contents. And once you identified that need, then you eliminated the need for surgery or endoscopy or anything like that. You just said, give me anything, the easiest, simplest method to exclude the duodenum from luminal contents. And this was the genesis, again, this was the biodesign team at our Hopkins Center. And some of you might know Ashish Nimgamkar, who was my trainee at Stanford and joined me at Hopkins, and now is the CEO for this company called Glycin. And what is the idea? Basically, it was about giving an oral mucoadhesive that stuck to the duodenum at the right pH. And once it did it, it basically prevented contact from duodenal contents, or from duodenal contents making contact with the duodenal mucosa. And you can see in diabetic rodents, just simple gavage of this material had a highly significant effect on postprandial hyperglycemia. And with that, we were able to raise this last year or this year, early this year, $20.5 million to advance this now to human trials, which will begin next year in Australia. But it started with that refinement of the need statement. We would never have come up with a solution if we had simply said, I just want to do what gastric bypass surgery does, but maybe less invasively. So that is the biggest lesson I've learned, but there are other lessons I've learned, which I'll briefly talk to you about. First of all, innovation is not a black box. Okay, many people think, oh, you either have it or you don't have it, and I can never learn it. Actually, innovation can be taught and it can be learned. This is an article we published in Gastroenterology several years ago about the whole biodesign learning process. It's very elaborate. It's very formal. It's like taking a course in organic chemistry. It's structured. There are steps. There are methods. And they're scientific. And so you can teach people innovation and you can learn innovation. And again, the top two boxes here are all about the needs. And then there are many other things which I don't have time to go into, but I'll encourage you to read this article. And if you want, the book, which was written by the Stanford biodesign people. The other lesson I've learned, and this is obvious today when Nagi was talking about bile stents and Vivek was talking about PRCP. You know, as a doctor, no one has more passion for patients than you as a physician. And the welfare of your patient is paramount to you. But the welfare of the patient is not just about giving them what's available today, but coming up with solutions that are not available today. And that's really part of the commitment you make to the patient as a doctor. And this is a very important driving and motivating force, at least for me. I'll give you an example. I mean, you know, I started off as a therapeutic endoscopist. I was the first therapeutic endoscopist to be trained at Hopkins. And I thought I'd spend my whole career doing ERCPs and invasive procedures. But because of the work I did with botulinum toxin, people assumed I was a motility expert, which at that time I was not. And they started sending me patients like this, 35-year-old nurse with diabetic gastroparesis, nausea 24 hours a day, vomiting. And there were no solutions. There were no solutions for her. And this is what then motivated me to start going into the biotech side, into the pharma world, because no company at that time was interested in coming up with a solution for gastroparesis. As I like to say in this cartoon, there was no cure. There was not even a race for the cure. So when I was at Stanford and I got tired of seeing these patients in my clinic without offering them a solution, I said, okay, pharma's not going to do it. What can I do? Surely there must be something that I can at least try, even if I don't succeed, because if I don't try, then I'll not have lived up to my commitment to this patient. So I went on this search for a chemical database. You know, I spent 6 months searching for a drug that worked like metoclopramide, did not cross the blood-brain barrier, and unlike domperidone, did not have any heart effects, cardiac side effects. I found a lead compound, which is actually available in France, of all places, and was being used in France for 50 years, but had never been tested before. We were able to get it. We were able to actually file a patent on it, which was a miracle on its own, and got that patent approved. We formed a company, spent 5 years, 5 long years, trying to raise money. Nobody was interested. And then finally, 3 years ago, we raised $45 million. And this week, actually, I'm pleased to say that our phase 2 trial has recruited its first patient. So we don't know it'll work. It looks promising, but it's not easy. It's been 10 years of that journey. And the only reason that I stayed in that journey was because, like so many of you and all of you, I had that passion to do something different for my patients. The other thing that starting thinking about entrepreneurship or trying to commercialize actually forces you to be very rigorous in your thinking. And I found that actually reinforces the way I think as a scientist when I'm applying for an NIH grant is very similar to when I start putting an idea in front of investors. You know, in the NIH review criteria, some of you are familiar with this. On the left side, we are judged by these 5 criteria: significance, innovation, approach with investigators, what the environment is. And these are parallels when you start going to investors with an idea. The significance is the unmet need, the market size. Innovation, of course, is the IP. The approach is the preliminary data, but also very importantly, have you checked out the regulatory status? How easy is it to get FDA approval or the equivalent in India? Who's going to pay for it? Is there a reimbursement strategy that actually you can employ? And of course, the scientific business teaching, innovation teaching. The other lesson I learned is that clinical care, research, and entrepreneurship actually feed on each other. These are not separate silos. If you are doing active research, it doesn't matter, clinical, translation, bench, your ideas deserve to get in front of the patients. And the only way they can get in front of the patients is if you know how to take them to the market, because otherwise you're going to sell them out of your garage and probably go to jail. So as you mentioned, you know, one of the things I learned as a fellow was pneumatic dilatation for achalasia. But, you know, very soon, and I'll tell you why, I realized that we had to start taking more risk if we are going to disrupt how to take care of patients with achalasia. I had my first perforation as a fellow in 1989. And I said, there must be a better way to do it. And you know the story. We said, let me inject botulinum toxin, first did it in pigs, and then did it in a human for the first time. My chief of the GI division at that time, Mark Donowitz, took me aside before the procedure and said, I heard you're going to inject botulinum toxin in a human. I just want you to understand that the division is not going to cover you, and I hope you have a good lawyer. So risk-taking is part of the entrepreneurship. Anyway, obviously botulinum toxin was useful in some patients, but for the majority of patients, it wasn't really a solution. And that's where we led to, okay, the myotomy concept, right? Myotomy was the best way to take care of achalasia, but was there a better way to reduce muscle competence? That was the unmet need. And that was the need statement. And that's what led to POEM. But it's still not a cure. POEM is still palliative. And therefore, from my basic science work with neural stem cells in the gut, which we identified 3 years ago and published in this paper in PNAS, we said we should now be thinking about transplanting stem cells into the esophagus. And this year, in February, we did our first human case of stem cell transplantation in the esophagus. So far, so good. No adverse effects. We're going to follow up, see whether he responds, what the objective improvement is. But it was a risk. But it was a risk, a calculated risk, and it is an extension of the finding the right unmet need. The unmet need here was how to restore neural function in achalasia and thereby cure it. And just for the last few minutes, this whole stem cell idea may seem too complicated for many of us who are not into enteric neurobiology, but it doesn't have to be complicated. The best ideas are often the simplest. This is Halstead, founder of American surgery, first chair of surgery at Johns Hopkins, along with Osler in medicine. He had a problem that his head nurse in the OR, who was actually his mistress on the side, by the way, a side story of Halstead, he was a heroin and cocaine addict. I don't know if you know that. And he remained that throughout his life, because at that time, a lot of these people were experimenting with cocaine. And they used to wash their hands with carbolic acid and disinfectants, and his nurse started having skin rashes on her hands. And he came up, he asked the Goodyear company, which is the rubber company, to make a glove for her. And that was actually the original glove that they made for her. And she started using that, and then they started using that, the surgeons started using that, and that's really how gloves were introduced for modern American surgery. Now, shouldn't give all the credit to Halstead, because the Europeans had already started thinking about using gloves, and some of them were using gloves, but American surgeons had resisted it. But this particular problem of reducing the skin irritation led gloves to be widely adopted for surgery. And why do I bring that example up? I bring that example up because many of you who do ERCP are very familiar with sort of, people talked about the biggest problem in gastroenterology from a medical legal perspective being post-ERCP pancreatitis. Well, this is a huge problem too. And this is the incidence of scope contamination. You're all familiar with that, so I won't go into that. I just want to set that as a background for what the unmet need was. The unmet need was not, in my mind, not how to disinfect the scope better, whether it was ultraviolet or irradiation or whatever chemicals you want to use. The unmet need was how to prevent infection in the first place, how to prevent contamination in the first place. And that's where the glove analogy came in. So basically, we wanted to prevent two-way contamination, just like the glove prevents contamination between the patient surgeon and the surgeon patient. We wanted to have a solution for the duodenoscope. And we came up literally with a glove for the scope. I remember that we were at DDW 4 years ago, and this was the hot topic. And I met with my collaborator in industry. And I said, Scott Miller is his name. I said, let's stop doing what we're doing and come up with a solution. And this was Scope Seal. And within 24 months, we really had close to a finished package, and now it's FDA approved, and I'll talk to you about this. But these are the problem with the glove for a duodenoscope was, of course, the optics. Could we come up with something that was completely sealing, but also preserve the optics? And bottom two are images with and without the scope seal, and you can't really tell the difference. So yeah, the technology summary, it is like a skin that goes on the distal end of the ERCP scope. This has been published now, so I don't need to go into details. Please refer to the article in GIE. But this is what the scope looks like with the seal on. You can barely see it. And you deliver it with a very simple mechanism. We've tested it in dye immersion tests. It prevents even nano-sized particles from getting into the scope. We tested its ability to protect against microbes that are introduced from the outside. Again, I don't want to spend a lot of time on the details, but we contaminated the scope with the scope seal on, and basically you have 100% contaminations without the scope seal and 0% contamination with the scope seal. This is from the patient to the duodenoscope. But if you have a duodenoscope that's already potentially infected and it's hard to get rid of, this also prevents contamination from inside out. So if you have a microbial challenge inside the scope, especially around the elevator with the scope seal on, there is no leakage of that bacteria into a solution that you immerse it into. And then the optics are just as good. And this is some sophisticated tests we did that involve MTF, which is a standard way to look at the optics and the resolution. And these are just visual examples in an animal with and without the scope seal that show the optics are very nicely preserved. And it allows us to work with all of these instruments shown here without any difficulty. And of course, there are other solutions. And I'm saying this not to tout this technology, but trying to reinforce the point of finding the right unmet need. You can say the right unmet need is, oh, better disinfection, but that has its problems as shown here. You can say the right unmet need is, well, just take the distal end out. That has its problems. And then, of course, you can have a completely disposable duodenoscope, as some companies are trying to do. And yes, you can eliminate the risk, but the costs can be prohibitive. And the quality imaging and others are still issues. But if you had the right unmet need, you would come up with what we think is the best-in-class solution. And it wasn't because we didn't think of those other things, but we had identified the unmet need. So in conclusion, lessons I've learned, no one has more passion for patients than you, so don't think somebody else will come up with the innovation. If you have an idea, take it all the way. Entrepreneurship teaches you to be rigorous in your thinking. Your clinical care and research can feed on your innovation. You need to be able to take risk, but you need to also be able to contain it. The best ideas can be the simplest. And entrepreneurship is not a way to make money for physicians. Entrepreneurship is a way to take your ideas to patients, which means taking them to the market. So if you really want to take your ideas to the patients, you have to learn how to be an entrepreneur. And again, the key is to correctly define the unmet need. The unmet need paradigm is similar to the nail and the hammer paradigm. The traditional way of innovation in medicine is, I have a hammer. I just came up with a device. I just came up with a drug. Now I want to find where I can use it. So you go around looking for the nail. The right way to figure out the unmet need is the patient-centric way. Identify the nail first. This is the unmet need. And you know what? You'll be surprised. There are 20 different kinds of hammers that you can use if you know where the nail is and what the nail is. And finally, I don't want to dismiss this. You just need one more thing. Okay, I'll give you a little quiz before I give you the answer. Name the most innovative automobile company that you can think of. Everybody says Tesla? Yeah, I assume. Okay. Okay, I'll give you a hint. Clean energy, of course, Tesla. All right. In 1912, more than 100 years ago, the Detroit Electric Company produced this car that could go up to 60 miles an hour for up to 40 miles on battery. All right. And it was very popular. So what happened? What happened was the discovery of gasoline a few years later and made it very, very cheap, and people switched to gasoline, and this company died. Although 100 years ago, it was clean energy, efficient, non-polluting. Think of how the world would have changed if we had stuck to this kind of automobile. So what else you need? You need luck. Luck needs to be on its side, and I have no way of telling you how to get that. Maybe you can do a mantra or something, but that's up to you. So thank you very much.
Thank you, Pankaj, for that outstanding lecture. In fact, lecture itself was very innovative for all of us. So, of course, we don't have too much time for panel discussion, but we didn't want it to be a very structured panel discussion because this is a topic that requires a lot of free thinking and innovation. So we left it very free. I have a very distinguished panel here. I don't know how many of them are there. Dr. Sneha John, Dr. Manish Bhatnagar, Dr. Banka, Dr. G.N. Ramesh, and Dr. Deepak Chowdhury. I think we'll start with Dr. Deepak Chowdhury. His thoughts on this. I think we've had a fantastic talk by Jay. We all know that when we watch and listen to him speak, we all think maybe we can become innovators, but I don't think it's as simple as that. I think it's a different mindset that's required. Deepak?
Thank you for having me on the panel, and it was a wonderful lecture, Pankaj, and innovative and very motivating. Maybe we all physicians start thinking like entrepreneurs, and maybe we'll come up with something in future. I have a question for you. You have done so much work with innovation. Where is artificial intelligence coming into GI and other related medical fields in near future?
Jay, you want to take it up? Yeah.
You want me to answer that?
Yeah.
Yeah, Deepak, thank you. Of course, artificial intelligence is here, not just for endoscopy, it's here for every aspect of our life. So artificial intelligence is one of those pervasive, universal technologies that will transform everything we do, whether it's in medicine or even, it's already doing that, right? Your Google searches are all based on artificial intelligence. So every aspect of your life is now going to be algorithmized in some way and subject to machine learning and artificial intelligence, which are related concepts. So I'm not surprised that we've seen in the last year itself, but in the last 3-4 years, this steady drumbeat of going to artificial intelligence and machine learning for solving some complicated problems. We produce huge amounts of data, even with a simple endoscopy, 99% of which the human brain is incapable of capturing or analyzing. That data is going waste, right? And so that is the power of artificial intelligence, is basically, and that's what it, in its truest way, that's what artificial intelligence should do. Come up with an intelligence that's beyond the human, not necessarily to replace it, but to inform it. So I'm as much an expert in artificial intelligence as a layperson in some ways, but I've kept abreast with the developments, and I think, yes, we will see improvements in how we analyze information for sure, but it's up to us then to utilize that advantage for true unmet needs, right? And that's the difference. That's just another technology. And then if you go back to that analogy of the hammer and the nail, then you're going to be looking for the nail for artificial intelligence for everything. You need to find the right unmet need and say, this is something that needs better data processing, information, analysis that no human being can do on their own, and will solve a critical unmet need. Otherwise, you can apply artificial intelligence to everything we do. Sorry, I don't want to belabor that. Sorry, but very nice question. Thank you, Lisa.
That's a very nice point that one should look at an unmet need. And I think already in endoscopy, we have an unmet need of a less qualified endoscopist trying to make a complex diagnosis, and AI now coming into endocytoscopy and so on to help us. I think one of the innovations that occurred in this COVID period is this telemedicine. So we have Dr. Sneha John right from Australia talking to us. So we'll take her comments now, Dr. Sneha.
Thank you, Professor Reddy, and it's been fantastic to listen to Professor Pasricha.
I'm sorry we picked up so late.
I know, it's actually 2 o'clock in the morning for me.
Wow.
So Professor Arora has a very persuasive manner, so I couldn't say no when he
Well,
asked
you know,
me.
his persistent manner is to send you a message every 5 minutes. That's what he's been doing since last night to me.
But we are early risers in Australia, so I don't mind. And this is such an exciting topic. So I was very moved by the fact that you said innovation can be taught. And I particularly enjoyed the fact that you said no one has more passion for our patients than we do. And to me, those were the 2 points I'd take away. So in answer to your question, Professor Reddy, in terms of showing that passion with telemedicine, we've recently done a survey of a lot of trainees from, including India, both Europe and Asia Pacific, and education and maybe being out of touch with what is happening in their field was one of the major concerns raised by a lot of trainees all around the world during COVID. So in answer to that particular query about telemedicine, yes, it's an innovative way of educating. And perhaps there was a need for that even before COVID. And perhaps there are good things we can learn from this. If I may say something about the artificial intelligence area that you talked about, because my focus is in upper and lower GI endoscopy. One of my really good friends has this very nice way of putting it and making this an analogy with driving, because they're in Germany and cars are everything. And they say, look, if you learned on a manual, you can drive any car. If you only ever learned on technology and an automatic, perhaps it's very difficult in certain situations, and that the cognitive ability of the driver is not taken away by any technology in the car. So perhaps AI for me, when I think about how we might put this into practice, particularly for our next generation, I believe as teachers, maybe, yes, we should teach them innovation, but we should start also by teaching them the basics very well so that they know how to use the innovation, look at the unmet need, find the unmet need. And in my world, this is still how to help the whole world of endoscopy, not just elite academic centers, improve detection of early GI neoplasia. And if we thought about AI as a fairly expensive technology, maybe in the first half, there's still a lot of unmet needs we can still cover without AI by helping colleagues in all parts of the world achieve those.
That's an excellent point you made about the artificial intelligence, that the danger, and lots of dangers people talk about, but one of the dangers is it creates another barrier between the physician and the tools. So, you know, the cars, for instance, you know, when I was in India, I had this Fiat car, Premier Padmini or whatever. I knew exactly how to fix it if anything went wrong. Pop open the hood, change the spark plug, carburetor. I knew exactly what everything was because it was simple. Today, I mean, I would not dream of opening the hood without going to a garage first, right? Because it's just too complicated. And there's a danger. Even that happens with patients, with our patients, and with the technologies that we use for our patients for that barrier to come in. The other thing about the telemedicine thing, you know, we've been practicing telemedicine now for the last 6 months, as everybody else has. And there are unmet needs there, not just in terms of, you know, the education and all that. There is a missing factor, right? The contact, the ability to form the bond, especially with new patients. With follow-up patients, it's easier.
Yeah.
And this is an example of, you know, the opposite. Maybe there's technology that can help with that and make that experience more real than it is today. So that's another example of what the unmet need is, if you identify the unmet need, it's not just having better connectivity or your better background or whatever Zoom embellishment you want. It's really, how do we restore that relationship? And that may be I'm not saying it is, but it's room for technology. You know, and I don't want to go back to that previous talk on with Vivek, but I was struck by one thing, and I wanted to talk to Ajay if I could make a comment. Post-ERCP pancreatitis was recognized by the panel as a huge problem by gastroenterologists, and Ajay said it is recognized by the Board of India and the ethics. I want to ask you, who in the ERCP community who recognizes this as such a huge problem has actually done research on what the biological basis of post-ERCP pancreatitis is? Nobody. Why not? And I don't mean this as a criticism. I'm saying, think about the unmet need. The unmet need only will happen if you think about it. It's not simply just trying one drug after the other or one stent after the other. Let's first understand what is the biological basis of post-ERCP pancreatitis. And there are clues. You know, we have published papers on some of those clues. I'm not saying they're true, but this community who is engaged and has a passion for preventing post-ERCP pancreatitis should invest in that kind of research as well. In the kind of research that actually exposes what the true unmet need is. That's the point of it. Sorry, I don't want to go over my time.
Jay, that was a fantastic talk. Yeah, I'm sorry, if I may.
Go ahead, please.
15-20, this is exactly the line of thinking. My question 20 years ago was, when a surgeon does a scalpel incision and a Whipple, patient doesn't get pancreatitis. Here we put a little wire and patient gets pancreatitis. Nobody has ever been able to answer that question, is that Bovi-induced surgical trauma doesn't create any pancreatitis.
So,
and, you know,
Vivek,
so
I'll send you a paper. I'll send you a paper, and maybe you can do a trial with collaborators in India.
Good question.
Yeah.
Thank you.
Thank you.
Just
So
GI is coming with a full issue on AI, just as a FYI, very soon. It was supposed to be September, but it is deferred for COVID. And the other thing with AI is a perfect example of hammer and nail. AI is a technology finding a use. And I think more than endoscopic applications, I think systems applications, such as telemedicine, such as improving our processes, that's where it'll probably find the maximum value, not in recognizing polyps.
Thank you, Vivek. I think we have another leader in gastroenterology in India from Mumbai, Dr. Banka, who's actually a lot of innovations, Dr. Banka, in practice. He's an innovator in practice. So maybe you can give us actually this question which Pankaj brought about of how you can improve your practice with telemedicine.
Wow.
Any suggestions, ideas on that?
Nagi, it's so, you know, I remember of an article. Can you hear me? Is it possible?
Yeah, we can hear you.
Okay. So, you know, listening to Jay reminded me of an article written by John Dewitt and Van Dam during the Diamond Anniversary of Gastroenterology 2 years ago, 2018. And he had written an article about innovations in endoscopy. And when I was listening to Jay, everything fitted into that. You know, he summarized the entire thing as the innovation expanding so rapidly and expectations must be tempered as research is performed to determine safety, outcomes, patient preferences, quality of life, training required, and cost of the procedures. I think, Jay, everything fitted in so well today. I enjoyed your talk. Thank you so much. Thank you.
Thank you, Manka. We also have Manish Bhatnagar, who's, of course, also a leader in the field from western part of India. And Manish, your comments on this?
Sir, good evening. It was indeed a pleasure to listen to Dr. Pasricha after 3 years. He visited Ahmedabad and he talked on innovation 3 years back. Obviously, this is a more updated talk Dr. Pasricha gave. I think, sir, there's nothing much to be added to what all the luminaries have said. I think we have two major innovators I know of. In India, it's you, and abroad, it's Dr. Pasricha. We know the innovations which are going to be technologically driven in terms of better optics, better instruments, better techniques, new technologies, which will definitely come. My only fear is that artificial intelligence may blindside us if we get too focused on AI, which may happen. There are some sci-fi movies which have explored this option, which is obviously out of the mandate of this particular discussion. But I think AI can never be a substitute for native intelligence. I think we'll still need to go back to the basics. And like you rightly mentioned for telemedicine, that touchy-feely thing to establish the rapport with the patient can never be substituted by a screen. Like Dr. Pasricha said, maybe there needs to be a need statement which takes care of this thing, and we could look at the innovation. Not everybody can be a teacher, an innovator, a scientist, a motivator, and also an entrepreneur like you and Dr. Pasricha. But I think for lesser mortals like us, I think new innovations are obviously a blessing, but we shouldn't get too fixated on the technological prowess part of it.
Thank you, Manish. On that humbling note, I think we should end this very important session. This was a really innovative session with so many, the great talk that Pankaj gave, and then, of course, the nice comments we had from the wisdom pearls that we had from many of our panelists. I'd like to thank you very much and thank Anil for giving us this opportunity. And even I can see late part of the night, so many people are hooked on watching this program. Thank you, Anil.
Thank
you. Thank you, Dr. Nagi. It was a pleasure to listen to Dr. Pankaj Pasricha. Pankaj, if I have to summarize your talk in one sentence, if you cannot become the Nageshwar Reddy, at least I can become the Pankaj Pasricha tomorrow, because you said it can be taught, which I thought I can never learn. Thank you for telling us that entrepreneurship can be learned. So we can become Pankaj Pasricha one day if you keep
Absolutely.
trying.
Absolutely.
But we can never be Nageshwar Reddy because it's so good above all of us.
No, nobody can be Nagis. We agree on that.
Thank you so much for telling that it can be taught. I thought it was inborn, it can never be learned. With that, we come to the end of the present session. I am thankful to all the panelists who have taken their time off their busy schedule to enlighten us on the innovation in endoscopy. And I am again thankful to Pankaj for answering a lot of questions which I could not get answered during our stay in the hostel at All India Institute of Medical Sciences. With that, we end up this session, and may I request, as is the customary program, may I request one of our colleagues from Gangaram Hospital, Dr. Mandhir, to give us in 5 minutes the summary of the day, so which is a recap of those who have joined late and may have missed one of the sessions. Dr. Mandhir, please.
Thank you, Anil. We had wonderful sessions tonight. We had total 5 sessions. The first was on idiopathic recurrent acute pancreatitis, which was delivered by Dr. Pramod Gar. I'll just summarize what he said. It can be defined as 2 or more attacks 3 months apart with no evidence of chronicity and with no evidence of obvious cause of pancreatitis. Biliary microlithiasis has been overrated as a cause of idiopathic recurrent pancreatitis. It occurs only in 10 to 15% of the patients as a cause, not as 2/3 cause as it was thought before. To make sure that it is the cause of pancreatitis, deranged LFT is very important. If it is not there, it is unlikely the cause and it is just an innocent bystander. And EUS is the best modality to diagnose microlithiasis with a 96% sensitivity. Pancreas divisum is not an important cause, and SOD is probably highly overrated and does not exist. And as a cause of idiopathic recurrent pancreatitis, it progresses to chronic pancreatitis in almost 50% of the patients. So usually it is an early chronic pancreatitis, which can also be diagnosed by endoscopic ultrasound. Genetic mutations, SPINK1 and CFTR account for 50% of the cases which are left in such cases. In patients who are more than 50 years of age, please rule out an occult malignancy as a cause of pancreatitis, and investigations should be done approximately 8 to 12 weeks after the attack of pancreatitis and include MRCP, and endoscopic ultrasound. During recurrent attacks, there is no need of getting repeated CTs, and antibiotics are not needed during such attacks. The second talk was about pancreatic cysts, which was delivered by Dr. Sandeep Laktakia. He started with the word that it is confusing, and it is really confusing. And the cysts can be detected in almost 2.5 to 13.5% people, and they become common with increasing age. And they can be seen in up to almost 40% of the persons who are undergoing MR or MRCP beyond the age of 70 years. Pseudocysts are a common cause. Serous cyst adenomas are the other important cause. They are usually asymptomatic and should be followed almost yearly. They need surgery if they cause compression symptoms. SPEN always needs surgery because this occurs at a young age. The patients can have, for diagnosing IPMN or cystic lesions, MRI and MRCP is the investigation of choice, and 40 to 50% are easily picked up, and one can diagnose whether they are arising from the side branches or from the main duct. And benign versus malignant can also be differentiated in almost 2/3. How to manage these is unclear. However, if the symptomatic, then EUS can be done as a supplementary investigation. And IPMNs need surgery if they are more than 3 centimeter, if there are mural nodules, if there is a dilated duct associated, and if there is a positive cytology for malignancy, or the patients are having jaundice. If the fluid is aspirated, which may or may not be done, then CEA is an important thing to diagnose that they can be mucinous. And 192 level is taken as cutoff. Cytology is only 1/3 sensitive, and mural nodules and thick wall are more important. Upcoming investigations are cystoscopy and confocal laser endomicroscopy. Other alternatives to surgery are EUS guided treatments by injection of alcohol or paclitaxel, and even RFA of the cyst can be done. The third talk was delivered by none other than Dr. Nageshwar Reddy, which was very clear. His first point was to exclude that the patient has PSC or not, where cholangioscopy and FISH are very important. And dilatation of the stricture is the treatment of choice. Then came whether it can be benign or malignant. For diagnosis of malignant strictures, for the distal strictures, EUS FNA was the modality of choice because tissue is the issue while diagnosing malignancies. For proximal strictures, one could go for cholangioscopy, especially in indeterminate strictures by CT, MR, or EUS. And cholangioscopy in various studies has shown a sensitivity specificity of more than 85%. In their own study, they have found that it is more than 95% sensitive with an accuracy of almost 88%. Then there was a newly coming concept of extracellular vesicle in the bile, which is almost 100% accurate, and it is done by collection of bile and is done by nanometer. Then the other thing which was brought up was which stent to be used in malignancy. Always it is the SEMS which is better. In proximal strictures, in type 1, 2, and 3B bismuth, unilateral stenting would suffice. While in 3A and 4, it would be the bilateral stenting which would be required. Whenever required, always take the help of interventional radiologists, especially in type 4. And to increase the stent patency, add photodynamic therapy, RFA, or brachytherapy. RFA is very important, and it can increase the patency by almost 3 to 6 months. And as of now, EUS bile drainage is still in a primary stage and should not be taken as the primary modality of treatment. For benign strictures in the proximal, especially due to post cholecystectomy strictures, multiple stents is still the treatment of choice for 12 months. For distal strictures, especially chronic pancreatitis, if not associated with a mass or extensive calcification, covered metal stents for 12 months, removable stents are the treatment of choice at the present. However, multidisciplinary approach is always better. Never shy away from consulting a surgeon or an oncologist. Always take their help. The next topic was by Dr. Vivek Kaul for post-ERCP pancreatitis. According to his talk, ERCP is the most risky procedure, and apart from bleeding, perforation and infection, which can be managed by different modalities, pancreatitis is the most life-threatening and life-altering complication with an incidence of approximately 3.5%. It can be diagnosed if you have 2 or more of the following: pain after ERCP, more than 3 times rise above the upper limit of normal of lipase or amylase, or CT scan is if suggesting. The risk factors of patient risk factors are: if the patient is less than 60 years, female patient with history of SOD, and with normal extrahepatic or normal CVD size, prior history of pancreatitis, and history of acute pancreatitis in the past. So we have to choose the patients in a proper way, and there should be nothing known as diagnostic ERCP anymore. ERCP should be done with a therapeutic intent always. Then the risk factors otherwise are basically risk difficult cannulation, if we have done a pre-cut, multiple contrast injections, if we have put in fully covered SEMS, and if we have done a endoscopic biliary dilatation without any endoscopic sphincterotomy. So to prevent such incidence of pancreatitis, one can go for guide wire assisted cannulation, prophylactic PD stent, especially if we have done multiple cannulations and multiple contrast injections in the PD. Then rectal indomethacin, which is going to be shortly available in India also, or rectal diclofenac. IV fluids is the most simple thing which we can follow, especially ringer lactate at a rate of 3 milligram per kg per hour, which can be started prior to the procedure. And somatostatin was another thing which is still under trial. Always anticipate problems, take a proper consent, because otherwise we can face a lot of medical issues. And always define an indication. Never take ERCP lightly. Manage once it has occurred in a proper way, like any other case of acute pancreatitis, with fluids, monitoring, good pain management, incentive spirometry, and other things which we normally do. I don't think we need to summarize the talk of Dr. J. Pasricha, because it was all innovative, except that we look forward to stem cell therapy for achalasia cardia, and we should await the glove of the scope tip, that is scope seal, in future. Thank you very much.
Thank you, Mandir, for giving a very apt summary of what we have learned from today's proceedings. As a tribute to our speakers, moderators, and expert panel members, I'm happy to announce that we have about 3,000 people who are still glued on to their TV, laptop, and the mobile screens to listen to this excellent talk. I do apologize for having overstepped the time, because the content of the talk was so good, the discussion was so lively, I didn't want to interrupt the good quality speakers. With that, may I request Dr. Ashish to propose a vote of thanks and invite everybody for tomorrow's session. Dr. Ashish, please.
So on behalf of the organizing committee of clinics in Hepato-Biliary Disease 2020, organized by the Institute of Liver Gastroenterology and Pancreatico-Biliary Sciences of Sir Gangaram Hospital, under the aegis of Delhi Liver Foundation, First of all, I would like to thank all the speakers for delivering very lucid lectures, covering all the recent advances and summarizing the content in the allotted time. I would like to thank the panelists and moderators for making each session very interactive and very lively. And since no conference is considered successful without the participation of the delegates, we are really thankful to all the delegates who participated, not only from India, but from across the world. And we had close to 3,000 participants, as Dr. Anil Arora said, which is really a huge number, and most of them remained logged in throughout the conference. My special thanks goes to all the international speakers and delegates who participated in spite of this being an odd time in their part of country, their world. And next, I would like to thank the Micro Labs as our academic partner for their logistic support. And last but not least, I would like to thank the event partner, My-Provide, and especially Mr. Pranav Vishwas for providing the excellent platform for this meeting with flawless management. I would like to invite all of you for the fourth day of the meeting, that is tomorrow at 5 p.m. Since it is a long session tomorrow. And the theme for tomorrow's meeting is recent advances in diagnostic and therapeutic endoscopy. With this, I end the session. I hand over to Dr. Anil Arora.
Thank you and good night, everybody. I hope you have a comfortable stay and thank you so much for being a part of our meeting. Look forward to seeing you tomorrow. Tomorrow the session starts at 5 p.m. Thank you and bye-bye.
Thank you. Thank you very much.
Yeah,